Welcome to the third night of the PSRC 2021 Pentathlon. Tonight's program will focus on craniofacial and congenital anomalies and will be co-moderated by Drs. Justine Lee and Brian Andrews. On behalf of myself, Dr. Gassman, Dr. Borchell, and the rest of the executive committee, we thank all of you for participating in this event. Drs. Lee and Andrews have put together an amazing program that we are confident you will enjoy. I will now turn things over to Dr. Lee.
Hi, everybody. Welcome to the Craniofacial night of the PSRC 2021 Pentathlon. I'd like to thank our wonderful roster of presenters and faculty for their participation. Before we get started for night 3 of the Pentathlon, a couple of rules and regulations. Please stay on mute out of respect for our speakers. Please be sure to have your camera off when the speakers are presenting, and you can turn your cameras on for Q&A. Please turn your cameras on for Q&A. We would all love to see everybody. Please participate in the Q&A sessions through the chat function. We would love to hear your questions. Be sure your screen name is your first and last name. And the PSRC Mentorship Committee is facilitating a breakout room. It's called Meet the PSRC Executive Committee, Getting Involved, with mentors Dr. Greg Borchell, Brian Gassman, Aaron Green, Allison Snyder-Warwick, and Alex Wong, who will be hosting this breakout room during the quick shot sessions, which will begin around 7:20 p.m. Eastern Time. Please take advantage of this opportunity to meet with everybody, meet with the leaders of our field, and really ask them questions or advice. Please plan to join us for our subsequent nights of the Pentathlon. Tomorrow, June 10th, will be transplant and microsurgery, and we're going to end Friday, June 11th, with breast aesthetic and gender affirmation surgery. Be sure to also follow the PSRC on social media and join as a member. The Research Council is the preeminent research organization in plastic surgery. We have so much innovation, so much energy going on, high quality science, and really just a wonderful, wonderful research community that we would love to have you, if you're not part of us, to be part of us. And I think that's all I have for opening comments. So now I would like to introduce our first invited speaker, Dr. Derek Wan from Stanford University, who will be speaking on deferoxamine treatment for radiation fibrosis.
All right, well, thank you for this wonderful opportunity to present some of the work that we've been doing in the laboratory on the treatment of radiation-induced fibrosis. These are some of my disclosures. We have a patent for improvement of radiation-induced soft tissue fibrosis and fat grafting, and our work has been funded by a couple NIH grants, as well as the PSF-NPF Biologics Allograft Tissue Research Grant. All right, so each year there are approximately 60,000 new cases of head and neck cancer and over 250,000 cases of breast cancer diagnosed in the United States. These are just some statistics pulled from the CDC Cancer website, and over the past 20 years, you can see a steady increase in these numbers. In total, there were over 1.5 million newly diagnosed patients with some form of cancer in the United States just in 2020 alone. Now, many of these patients will undergo radiation therapy as part of their treatment regimen. And while this undoubtedly improves survival, it's also associated with significant collateral soft tissue injury. Acutely, this can manifest with erythema, desquamation, ulceration, and pain. But the chronic effects can be just as, if not even more, debilitating. Now, unfortunately, there are very few effective treatment options for radiation-induced fibrosis. Many different strategies have been studied, but the clinical improvement has been hard to show. Physical therapy is probably the most common modality used, which can provide some symptomatic relief. And of note, fat grafting is a technique that we're all familiar with, and there are definitely several studies showing that this does seem to help. A part of the difficulty in developing effective treatment options for radiation fibrosis is the complex processes that are involved in the pathogenesis, many of which are incompletely understood. Some of what is known is that ionizing radiation induces direct DNA damage and generates reactive oxygen species. And the ionizing radiation interacts with water to form hydroxyl radicals, superoxide, and hydrogen peroxide. Now, normally, antioxidants and other oxidant-degrading enzymes help to manage these toxicants. But when they become overwhelmed, this leads to aberrant gene expression, activation of pro-inflammatory cascades, which can stay persistently upregulated for years and recruitment of inflammatory cells. And ultimately, this leads to cell death and tissue damage with excess production of extracellular matrix components like collagen. Now, to better understand some of the cellular processes involved in the development of radiation fibrosis, we've been doing a lot of work in the laboratory in mice over the past 78 years. Here, we irradiated mice delivering 30 gray and fractionated doses, and then began biopsying the injured skin over 8 weeks. And as expected, over this timeline, you begin to see worsening injury with thickening of the dermis on H&E staining, seen in the left column, and more collagen deposition with loss of cellularity seen here in these other two histologic stains. Now, to provide more detailed discrimination of changes in the extracellular matrix, we used a novel computational algorithm developed by our laboratory. And basically, Picker-Sirius red stain sections shown on the previous slide were skeletonized, and several different collagen fiber parameters, such as length, width, and angle, were extracted and then plotted in multidimensional space. These then underwent dimensionality reduction to generate 2D T-SNE plots to visualize collective differences in collagen between the groups. On the right-hand side, we have color-coded each time point, and you can see the fibers at early time points were fairly similar based on the overlapping colors. And then over time, there is greater divergence away from normal skin for the irradiated skin, particularly at the last week 8 time point shown here in the pink. And we also look to see where remaining fibroblasts in irradiated skin come from, whether they represent a local expansion of resident cells already in the skin, or whether they come from circulation. So we parabiosed wild-type mice with GFP mice, and after confirmation of shared peripheral circulation, we then irradiated these mice and looked at the skin 4 weeks later after fibrosis had developed. In wild-type mouse skin, there were definitely GFP cells that we could see, but these were all overwhelmingly CD45 positive, meaning they're hematopoietic in origin. Using a rainbow mouse to visualize clonal expansion in regions of interest, we also noted at 4 weeks post-radiation, there were several contiguous regions of single colors, likely reflecting expansion from individual cells. So together with findings from the previous slide, these data suggest that all of the fibroblasts present in radiation-scarred skin developed from expansion of cells that were already there. But more and more now, we're beginning to understand that fibroblasts are not all the same. And there's been a lot of work that's been done in our laboratory lately to better understand some of these differences. Here we harvested all the cells from irradiated skin and performed single-cell RNA sequencing. And based on gene transcriptional patterns, we were then able to isolate fibroblasts from all of these other cells. But within this fraction, we actually found in irradiated mouse skin that there were 5 transcriptionally distinct fibroblast subgroups. This is a heat map showing the top 10 genes that help define each subgroup. Using the 100 genes for each of the 5 clusters that define them, we performed enrichment analysis of these gene sets to determine processes these fibroblasts may be involved in. Here, I've only shown 2 of the 5 clusters, which were particularly interesting. Cluster 2 seemed to be predominantly involved in TGF-beta signaling, which has long been known to be involved in scarring. And cluster 4 seemed to be involved in focal adhesion and mechanical signaling, which is another process where there's recently been a lot of buzz with in regard to scar formation. Well, back in 2015, our laboratories published this report in Science, which identified a fibroblast lineage which was implicated in wound scar formation. These fibroblasts were marked with expression of engrailed 1. To track these cells postnatally, we used an MTMG reporter such that all cells that turned on engrailed, even temporarily, were marked with GFP. All of the cells that never expressed engrailed 1 remained RFP positive. Here you can see that with wounding, as well as with radiation, the majority of the extracellular matrix in scar was green, implicating these engrailed 1 fibroblasts in scar formation. Just a few weeks ago, we published another study in Science showing that mechanical activation of fibroblasts can turn on engrailed 1 expression, and that blocking this process can allow for engrailed negative fibroblasts to participate in a more regenerative response in wound healing. Well, it turns out we can also track engrailed 1 positive fibroblasts through CD26 expression on the cell surface. So using CD26 as a surrogate for engrailed 1, we looked at our fibroblast subgroups in irradiated skin. Interestingly, it seems that most of the CD26 expressing fibroblasts are distributed within clusters 2 and 4, the same clusters we previously highlighted a couple slides back that seem to be strongly involved in the process of scar formation. So it seems there may be commonalities in fibrosis, whether it be from wound healing or radiation injury. And peripherally related to this, work from our laboratory also suggests similar recurring themes in other fibrotic processes throughout the body, including intestinal strictures, pulmonary fibrosis, and even tumor stroma formation. So now that we've begun to identify some of the cellular processes and pathophysiology involved in development of radiation fibrosis, one of the strategies that we've been investigating to treat this is deferoxamine administration. Now, I'm sure many of us are familiar with deferoxamine, but it's an iron chelator that's FDA approved and already in use for treatment of acute and chronic iron overload. Through local iron chelation, deferoxamine blocks PH2 function, which stabilizes HIF1 alpha, leading to downstream expression of pro-angiogenic factors. So local iron chelation also decreases formation of reactive oxygen species, which contribute to a significant amount of damage and radiation injury. The administration of deferoxamine has already been shown in animal models to improve ischemic flap survival, bone healing following radiation injury, and when directly injected to fat grafts, it may also enhance retention. So based on this background, we began looking at using deferoxamine for radiated soft tissue injury in our mouse model. Here we see through laser Doppler analysis following radiation treatment that there was a drop in blood flow at the scalp. However, with deferoxamine injection, there was an increase in perfusion shown in the red line in the chart up top. This was also associated with a slight decrease in dermal thickness of irradiated skin. But from a translational perspective, serial injections of deferoxamine into irradiated tissue may be difficult to perform. Therefore, we turned to a topical strategy developed by Jeff Gertner's laboratory. Deferoxamine by itself has an atomic mass of 561 Daltons and cannot efficiently cross the skin barrier, particularly since it's hydrophilic, which makes it difficult to traverse the hydrophobic stratum corneum. To circumvent these limitations, Jeff Gertner's group developed a topical patch delivery system, which encapsulated deferoxamine in a reverse micelle. This allows for transport through the stratum corneum, and then with disintegration in the epidermis, free deferoxamine is released. Here you can see how much better deferoxamine penetrates in reverse micelle form compared to when it's solubilized with just DMSO on the right. So building off of this work, we've studied use of the same topical DFO patch to treat radiated mouse skin. The first thing we looked at was DHE staining in irradiated tissue, which reflects levels of reactive oxygen species. And we found a significant reduction in DHE staining with DFO patch application. This was associated with a reduction in markers of cell death, including VAX and cleaved caspase 3. Looking at other skin assays, in the upper left-hand corner, you can see that just like with direct injection, topical delivery of deferoxamine was also capable of improving local perfusion in irradiated tissue. We also noted a reduction in normal thickness with the patch application and an improvement in both vascularity and skin stiffness, shown here in the bottom with CD31 staining and stress strain curves. But how does topical patch administration of deferoxamine directly compare to injection of deferoxamine? With staining irradiated skin for free iron with Prussian blue, we see a reduction in iron with both injection and patch delivery of deferoxamine. However, it seems that patch delivery of deferoxamine will be more effective at reducing iron levels in the soft tissue. In concert with this, we also looked at other markers of reactive oxygen species by staining for 8-isoprostane. This is a prostaglandin-like compound formed by free radical catalyzed peroxidation of fatty acids. While both injection of deferoxamine and patch delivery reduced 8-isoprostane levels, this was more significant with the DFO patch. This may reflect the fact that the patch delivery of deferoxamine allows for more continuous levels within the dermis. Deferoxamine has a short half-life on the order of a few hours, and daily direct injection may only allow for episodic transient presence of deferoxamine in the skin. Now, interestingly, many of our findings parallel other studies using the same deferoxamine patch. This was a report from Steve Buckman's group where saline expanders were placed into the back of rats and then expanded. Rats were then treated with radiation, and then some of these rats were administered the deferoxamine patch. In the photos, you can see deferoxamine treatment decreased skin ulceration as well as collagen disorganization. So all these mirroring studies have really served to establish the effectiveness of deferoxamine in treatment of radiation fibrosis. And moving one step closer now to clinical use, we have recently transitioned to pig studies where the skin is much more structurally similar to humans. So with this, we began by evaluating different deferoxamine patch dosages to determine effect in pigs. This is a schematic showing radiation recovery and then our treatment protocol with 3 different patch dosages of 0.5, 1, and 2 milligrams per centimeter squared deferoxamine. After 4 weeks of treatment, we see that with our 0.5 milligram patch, dermal thickness as well as collagen deposition was not significantly changed from irradiated untreated skin. However, both the 1 and 2 milligram patch showed similar reduction in dermal thickness and collagen content. And long-term biopsies were also obtained following cessation of patch therapy. And again, both 1 and 2 milligram patches had similar sustained improvement in dermal thickness and collagen content. Now, for all of these patch concentrations, deferoxamine delivery was limited to the skin, and there were no real systemic absorption detected. By mass spectrometry, deferoxamine levels within the blood were several hundredfold lower than concentrations detected when it's administered clinically. So basically, these were pretty much similar to background noise. We have now done more detailed investigations using the 1 milligram patch, and this is also the same patch concentration used in our earlier mouse studies. These are some photos of the irradiated treated sites after 1 month of patch treatment, and you can see there were no adverse skin reactions to topical deferoxamine. On H&E staining, we found a reduction in dermal thickness, which was already notable after 2 to 4 weeks. More importantly, when we stopped patch treatment and waited another 4 weeks, we found the improvements were durable. The same improvements were also seen for collagen content with serious red staining and vascularity with CD31 immunofluorescent staining. Both improvements were also durable with similar findings at week 8, which was again 4 weeks after we stopped patch treatment. We've now also performed single-cell RNA sequencing and isolated fibroblasts for further analysis. We found 6 transcriptionally distinct fibroblast subgroups shown here on the right in UMAP space. With the enrichment analysis, we were actually able to determine processes each cluster may be involved in. And in particular, we found an interesting cluster, number 1, which seemed to be a provascular subpopulation of fibroblasts based on gene expression. And this population was reduced with radiation of pig skin, but was noted to increase with deferoxamine treatment. Now, finally, here are some videos of skin pliability testing at treated sites. You can see that with no patch treatment, sites had very little pliability. And this was similarly noted in control patch treated sites. However, with deferoxamine patch treatment, there was much more skin pliability, and this was much closer to the non-radiated, uninjured skin shown here in the last video. So based on these data, we've already had a pre-IND interaction with the FDA to discuss our development plans for the DFO patch in treatment of radiation fibrosis. We've also met with some radiation oncologists to discuss development of a phase 2 clinical study. We'll be targeting patients with chronic radiation fibrosis with a clinical grade of 2 or greater. And our endpoint will be clinical grade improvement of 1 or more. Secondary endpoints will also be based on cutometer measurements of skin pliability as well as quality of life questionnaires. So once we obtain a formal IND and institutional IRB approval, we're hoping to get this study going in the near future. So I think these are very exciting times. Finally, I just wanted to thank some of the people in my laboratory over the past 5 years, which have contributed to all data that I presented, and I just wanted to thank them all for their hard work. So thank you once again for this opportunity to present some of the work that we've been doing, and I'm happy to take any questions.
Derek, thanks a lot. As always, your work's extremely impressive. I know I speak for Brian Gassman and myself in that we are anxiously awaiting the use of your patch for our head and neck patients, the near impossible problem currently to deal with clinically. So hopefully we can collaborate and use your patch in the near future on some of our patients. Any questions? All right, we'll now be moving on to our presentations. These are the top scored abstracts from the year. Our first presentation is haploinsufficiency of SF3B2 causes craniofacial microsomia. It'll be presented by Andrew Timberlake from NYU. Andrew?
Good afternoon, everyone. Thank you for the opportunity to present today. I'm Andrew Timberlake from the Hans-Jörg Wyss Department of Plastic Surgery at NYU. My presentation today is titled Haploinsufficiency of SF3B2 causes craniofacial microsomia. I have no disclosures. Craniofacial microsomia is the second most common facial anomaly, occurring once in every 3,500 live births. Many of us have come to know the condition as oculoauriculovertebral spectrum, as it truly represents a spectrum of malformation of the craniofacial skeleton and soft tissues, which might include preauricular or facial tags, microtia or anotia, mandibular hypoplasia, microphthalmia, epibulbar dormoids, vertebral anomalies, renal anomalies, or cardiac defects. Despite its prevalence, there are currently no known genetic causes of CFM. In an attempt to identify novel genetic causes of CFM, we recruited a cohort of 146 families who had either sporadic or familial CFM. We performed either whole genome or whole exome sequencing on trios for sporadic cases and affected individuals from multiplex kindreds. This allowed us to analyze the burden of both de novo and transmitted rare variants in these kindreds. In studying the 138 kindreds with sporadic CFM, we identified that while the total number of de novo mutations matched expectation at 1.1 per proband, there was a significant excess of de novo loss of function mutations in these kindreds, identifying a role for loss of function mutations in this condition. A single gene had 2 de novo loss of function mutation, which was the gene SF3B2. Identifying 2 de novo loss of functions in this gene in a cohort of this size surpassed thresholds for genome-wide significance. In analyzing the burden of all loss of function mutations in probands compared to the expected distribution, again, a single gene, SF3B2, demonstrated significant enrichment. In total, we identified 7 loss of function mutations in this gene. None of these mutations are found in large control databases with data from more than 250,000 alleles. The mutations were start loss, nonsense, frame shift, and splicing mutations that span the length of the protein, supporting haploinsufficiency as the mechanism of disease in these cases. SF3B2 has a PLI score of 1, which is the highest possible score, representing an extreme intolerance to loss of function mutation, and therefore a very high likelihood of phenotypic consequence associated with this mutation. SF3B2 is a core component of the major U2 spliceosome, which is responsible for recognition of the branching A in splicing that is ultimately responsible for lariat formation in introns that precedes intron splicing and exon joining. Interestingly, loss of function mutations in SF3B4, another component of the U2 spliceosome and binding partner of SF3B2, cause Nager syndrome, an acrofacial dysostosis that similarly affects the craniofacial skeleton and soft tissues. While 4 of our cases were due to de novo mutations or gonadal mosaicism, there were 3 multiplex kindreds with SF3B2 mutations as well. Phenotypes commonly involved tragal anomalies with or without preauricular or facial tags, unilateral or bilateral maxillary and/or mandibular hypoplasia, and cervical ribs. The ability to study a single family with 12 individuals harboring an SF3B2 mutation is also very revealing of the phenotypic heterogeneity of patients with these mutations. Within a single family, phenotypes ranged from isolated tragal anomalies or preauricular tags to severe maxillary and mandibular hypoplasia with lateral oral clefts, microphthalmia, and epibulbar dermoids. These findings strongly support the notion that oculoauriculovertebral spectrum is truly a spectrum that includes simple auricular malformations or microtia, all the way through the constellation of symptoms that we call Goldenhar syndrome. We next injected Xenopus embryos unilaterally at the 2-cell stage with SF3B2 morpholinos to study the effect of SF3B2 knockdown on cranial neural crest cells. As you can see here, with the right side of each image representing the injected half of the embryo, increasing doses of SF3B2 morpholino resulted in significantly decreased expression of SOX10, a reliable neural crest marker. Co-injection of human SF3B2 RNA rescued this phenotype. We expanded our characterization of the morphin phenotype by assessing the expression of a broader repertoire of genes expressed in neural crest progenitors, namely TFAP2E and SNAI2, or neural plate, SOX2. TFAP2E and SNAI2 were reduced similar to SOX10, and the SOX2 expression domain was expanded, consistent with a loss of neural plate border. At the tailbud stage, when neural crest cells initiate their migration into the pharyngeal arches, SF3B2 morphin embryos showed a marked decrease in the dorsoventral extension of the neural crest streams, as visualized by SOX10, SOX9, and TWIST1 expression here. At later stages, RUNX2 is defected in foci of cartilage precursors in the mesenchyme of the pharyngeal arches, and its expression in these domains was severely disrupted in SF3B2 morpholino-injected organisms. We subsequently analyzed later stage Xenopus to evaluate the long-term consequences of SF3B2 depletion on craniofacial development. For the lower doses of SF3B2 morpholino, namely 10 nanograms and 20 nanograms, we observed significant craniofacial defects affecting the overall size of the head on the injected side, while control morpholino-injected tadpoles were unaffected. The phenotype was even more pronounced for the higher doses of SF3B2 morpholino at 30 nanograms. Auschen blue staining revealed that neural crest-derived cartilages are hypoplastic or missing in SF3B2 morphin tadpoles. In conclusion, we identify a role for loss of function mutations in SF3B2 in a fraction of CFM cases, accounting for 3% of sporadic cases in our cohort and a quarter of familial cases, providing a genetic diagnosis in roughly 5% of all cases studied. These rates are similar to what is seen for ERF6 in cleft lip and palate and SMAD6 in non-syndromic midline craniosynostosis. We find that spliceosomal dysfunction leads to cranial neural crest defects that underlie the constellation of malformations observed in CFM, and our data supports the notion that microtia through Goldenhar syndrome represents a spectrum of malformations of similar pathoetiology. We're currently sequencing a substantially larger cohort of CSM families to identify additional disease genes and pathways, and beginning experiments to understand the mechanism by which spliceosomal dysfunction might actually cause the cranial neural crest defects observed in our animal model. I'd like to thank everyone at NYU and the University of Washington who are involved in this project, and thank you all for the opportunity to present today.
Thank you, Dr. Timberlake.
Oh, go ahead, Justine.
Thank you, Dr. Timberlake. As usual, a fantastic talk. Our next paper is still with Dr. Timberlake, is entitled Genetic Influence on Neurodevelopment in Non-Syndromic Craniosynostosis, and again, presented by Dr. Timberlake from NYU.
Hello again, everyone. I'm Andrew Timberlake from NYU. This presentation is entitled Genetic Influence on Neurodevelopment in Non-Syndromic Craniosynostosis. Craniosynostosis is the premature fusion of one or more cranial sutures, occurring once in every 2,000 live births. Roughly 85% of these cases are non-syndromic, presenting with no extracranial anomalies. Nearly half of all children with non-syndromic craniosynostosis have subtle neurodevelopmental anomalies despite optimal surgical management. While studies have assessed the contribution of both timing of surgery and type of surgical correction performed on neurocognitive outcomes, the potential role of genetic lesions affecting both cranial suture morphogenesis and intrinsic brain function have not been explored. We sought to determine whether the frequent aberrations in neurodevelopment observed in non-syndromic craniosynostosis are under genetic influence. Craniosynostosis is one of many congenital anomalies that presents with neurodevelopmental delays. For example, in congenital heart disease, a similar fraction of non-syndromic children have neurocognitive deficits despite optimal surgical management. A landmark study in 2015 demonstrated that mutations in genes that concurrently impact cardiac and neurodevelopment imparted strong risk of associated neurodevelopmental delay in children with CHD. We sought to determine whether this phenomenon might be present in craniosynostosis as well. We recruited a cohort of 404 case parent trios with sporadic non-syndromic craniosynostosis who underwent whole exome sequencing and compared this data to that from 1,789 control trios sequenced on the same platform. We analyzed the burden of de novo or sporadic mutations in affected children in each cohort and compared mutation burden across neurodevelopmental outcomes. Participating patients were enrolled from throughout the country and were treated across dozens of craniofacial centers. Each provided genomic DNA from buccal swabs from the affected child and both unaffected parents, medical records related to surgical treatment and neurodevelopmental delays, and self-reported demographic information. In comparing the burden of mutations in cases compared to controls, we found a strong enrichment for damaging missense and loss of function mutations in craniosynostosis cases. There was a metric in genomics called PLI, which is a score between 0 and 1 indicating how intolerant to loss of function mutation a certain gene is. Those in the highest 10% with scores greater than 0.9 are considered strongly intolerant. So mutations in these genes are likely to have substantial effect on an individual's fitness, which includes neurocognitive abilities. When restricting analysis to only high PLI genes, we saw an even stronger enrichment of mutations in craniosynostosis cases, with a nearly threefold excess of damaging mutations in craniosynostosis. Finally, when restricting analysis to only mutation-intolerant genes in the top quartile of expression in the developing brain, we identify an even more substantial excess of mutations in this gene class. Overall, the results imply that sporadic mutations in genes critical to neurodevelopment are significantly enriched in children with craniosynostosis. We collected information related to whether children had any neurodevelopmental delays, whether those were persistent past 6 years of age, and then characterized them as motor delays, speech or language delays, or intellectual disability. 63% of probands with damaging de novo mutations and intolerant genes experienced neurodevelopmental delays, compared to 31% of those who did not harbor these mutations. These children were 2.5-fold more likely to experience motor delays, twice as likely to experience speech or language delays, and more than 20-fold more likely to have intellectual disability. Considering only families with transmitted damaging mutations and intolerant genes, these children were also twice as likely to have any developmental delay. Across all types of delay studied, those with no damaging mutations and intolerant genes, represented by the purple in this figure, were significantly less likely to experience delays than those with damaging mutations and intolerant genes. Importantly, when considering the 180 children who were assessed past 6 years of age, those with damaging mutations and intolerant genes were 6-fold more likely to have persistent neurodevelopmental delays than those children who did not have these mutations. 39.3% of those with mutations had persistent delays versus 6.7% of children who did not have these mutations. Generally, comparing those with and without any delay, there were no significant differences in the mean age at which they underwent surgery, the type of surgery they had, or the need for revision procedures. There was also no significant difference in parental age, income, education level, or geographic location. Taken together, the results suggest that genetic lesions impacting neurodevelopment confer higher risk of adverse neurodevelopmental outcomes in non-syndromic craniosynostosis. We have focused strongly on the timing and type of surgery that these children undergo. However, the results imply that certain neurodevelopmental outcomes may be related to intrinsic brain dysfunction, as genetic lesions that concurrently affect suture morphogenesis and brain development may explain a substantial proportion of the neurodevelopmental delays seen in craniosynostosis. As we expand on these findings, genetic analyses could ultimately provide useful in identifying those children at greatest risk for poor neurodevelopmental outcomes, allowing for targeting of these children for early intervention. I'll finish by saying that I think the genomic revolution is well underway. The cost of sequencing a genome has been reduced by over 100,000-fold in the past 20 years. I think our clinics are going to be filled with patients who present with a molecular diagnosis even before plastic surgeons make a clinical diagnosis. And as we learn more about how genetics affects clinical outcomes, patient genotypes will begin to inform the way we take care of them. Moving forward, we hope to bring these findings closer to the clinical sphere. I expect that larger scale sequencing efforts will allow for more complete understanding of craniosynostosis genetics, wherein patients will undergo testing after diagnosis in order to identify those at greatest neurodevelopmental risk. One of my co-authors on this study, Alex Jun, has also recently conducted a battery of formal neurocognitive tests on a very large number of these patients from whom we have matched genetic data in order to quantify the effect of these mutations. With some very interesting data. We expect that she'll be reporting on this in the near future. Thank you to everyone involved in this project, both at Yale and at NYU, and thank you all for the opportunity to present this work today.
Dr. Timberlake, thanks again for both your presentations, very impressive. Our next presentation will be Monica Manrique from Children's Hospital in Washington, DC. She'll be presenting on her next paper entitled The Prevalence of Normocephalic Sagittal Craniosynostosis in Young Children.
Hello, my name is Monica Manrique, and with my colleagues from Children's National Hospital, we are pleased to present our abstract entitled The Prevalence of Normocephalic Sagittal Craniosynostosis in Young Children. We do not have any disclosures. Craniosynostosis is usually diagnosed during early childhood by the presence of scapulocephaly. However, patients with normocephalic sagittal craniosynostosis have been reported, and some groups have observed high rates of elevated intracranial pressure in these patients. Our team recently completed a retrospective study of 331 normal patients aged 1 to 5 years who underwent head CT scans in our emergency department. We observed sagittal suture fusion with a normal head shape in over 3% of our cohort. Interestingly, this finding was documented by the radiologist in only 18.2% of the cases. This project serves to validate our preliminary findings using larger cohort patients and aims to analyze factors associated with normocephalic sagittal craniosynostosis. After IRB approval, we retrospectively reviewed head CT scans in patients aged 0 to 71 months who presented to our ED for issues unrelated to their head shape or craniosynostosis, the most common being trauma. Patients with known craniosynostosis, history of hydrocephalus, or other known brain or cranial abnormalities were excluded. Demographic information was recorded as covariates. Subjects were classified into two groups based on the presence or absence of craniosynostosis, and differences between groups were analyzed. A total of 870 scans were reviewed. Sagittal fusion was observed in 41 patients. Of these, 25 patients had a complete suture fusion, shown in blue, whereas 16 had partial fusions ranging from 10 to 95% closure of the total suture length, shown in red. None of the patients had cranial index values under 0.7. A formal documentation of craniosynostosis was included by the radiologist in 4.5% of the affected patients. The most common indication for CT scan in this subset of patients was trauma in 53.7% of the patients, followed by headaches in around 12% of the patients, and seizures in 7.3% of the patients. When comparing between groups, craniosynostosis patients were significantly older. Furthermore, the prevalence of sagittal craniosynostosis increased up to 24 months of age and then plateaued from 24 to 72 months of age. This finding may imply this is not representing a tail of a normal distribution, in which craniosynostosis prevalence would be expected to keep increasing with time. Given the initial findings, additional analysis was performed between patients younger than 24 months of age and patients over 24 months of age. This analysis showed that affected patients under 2 years of age who presented with a family history of neurodevelopmental disease had 49.32 times higher odds of developing craniosynostosis. The subcohort encompassing patients above 24 months of age showed no variable as an independent predictor of developing craniosynostosis. Our study has a number of limitations that require acknowledgement. First, the CT imaging was done during the course of patient care in our emergency department, and accordingly, we cannot predict the exact age at which these fusions occurred. Also, there was a large proportion of African American subjects in our study compared to the general population, which is estimated to be 13.4% of the US population, reflective of the location of our facilities in downtown Washington, D.C. This may be considered a potential confounding variable, as the total of African American subjects in our study encompassed around 70% of our cohort. The question of whether our findings are broadly applicable to populations of children of other geographic regions or ethnic heritage requires further validations, and we encourage other centers with a different demographic to investigate their population prevalence. Lastly, because our investigation was retrospective, subjects with craniosynostosis lack of genetic testing and clinical follow-up. We now have a comprehensive protocol for identification and follow-up of subjects with craniosynostosis. In conclusion, neurocephalic sagittal craniosynostosis in young children is common. While the impact of this condition is unknown, the correlation with family history of neurodevelopmental disease is concerning. Therefore, new protocols that allow adequate early capture of phenotypically normal children with premature suture fusion should be considered. We are now instructing our neuroradiologists to check for fused cranial sutures in young children, and if any abnormality is observed, refer the patient to our neurosurgery department for clinical evaluation. Thank you.
Thank you, Dr. Manrique. Such an interesting finding. So now if we could have Dr. Manrique and Dr. Timberlake turn on their cameras, and I'd like to open this up to the attendees for questions and answers. Please feel free to use the chat feature, or maybe people could just speak up too if there's a question.
I have a question for Dr. Timberlake. Can you tell me about the gene for OAV that you've been looking at and how it compares to neurocrest apoptosis in Treacher Collins with genes such as treacle and POLAR1A, BC? Is there a similar type of mechanism and similar type of apoptosis seen as these cells migrate, or is it later function that happens, which makes it a separate entity?
Yeah, so as you mentioned, the mutations that have been identified in Treacher Collins in TCOF1 seem to affect ribosome function, ribosome biogenesis, with subsequent defects in neural crest cell formation. And like you mentioned, this seems to be related to apoptosis of neural crest precursors. And then basically it's a neural crest defect. We're still working right now with a combination of RNA sequencing as well as single cell sequencing to figure out where exactly in the process most of the neural crest defect is coming from. It does seem based on these preliminary studies that there is a defect in neural crest precursors, but then we also see a defect in migration into the pharyngeal arches as well. So we'll have to figure out exactly where in that process this seems to be coming from, but it does seem to be related.
Thank you. One follow-up question for your second paper. You've studied neurodevelopmental delays. What tests or how did you classify these delays in cognitive, speech, and motor function? Was there a certain assessment you used?
So no, this preliminary study is really just based on documentation by the treating surgeons, medical team, geneticists, et cetera, of what delays they had. And so these were basically binary outcomes of yes or no at this point. There are obvious limitations to that aspect of the study, which is why we're taking this a step further now and actually performing a battery of neurocognitive tests on these patients that we have matched data for in order to actually quantify those specific defects in each domain. But overall, this was really just a binary outcome of whether or not they were diagnosed, and then on subsequent examination, whether those were still present or whether or not those were things that persisted into their childhood or beyond.
Okay, thank you. This question is from Dr. Forrest in Toronto. Great work. What is the messaging to parents with effect to children for this work that you've done, Dr. Timberlake?
So for the second one, I assume is what you're predominantly asking for the genetic lesions. Kind of like I mentioned in the talk, we talk about what our data really tells us is best in terms of what surgery we should offer these children, when they should be operated on, et cetera. I don't think that this data, negates any of the things that have been studied over the past 10 to 15 years by so many people in this group and others who have really looked into that extensively. I think it adds kind of a third dimension to it, which is that you could perform an optimal surgery at the optimal time point. And as all the surgeons know, you can still have some very suboptimal neurocognitive outcomes. So I think there's still a very important role for surgery in mitigating risk as we are able to, but there might be a component that is genetically intrinsic, wherein even with optimal timing of surgery and a perfect surgery, we can't make any guarantees. And so the real aim of this, as we move this further along and flesh this out a little bit better, is not to say who needs surgery or who doesn't need surgery, but really more to start saying, you might be in a higher risk category. We might need to follow your neurodevelopment a little more closely, or even drive those families in the direction of early intervention programs in order to further mitigate any of those risks that might exist on a genetic basis.
Thanks. Well, if there's no further questions, I'll turn over to Justine and we'll keep moving along.
I think maybe one comment from Dr. O here, who wanted to underscore that Dr. Manrique's study may have major implications, because if 5% of normal cephalic patients are walking around with sagittal synostosis, the logical question is what we do now, given the studies that suggest asymptomatic increase in ICH in normal cephalic patients. So I guess this is more of a question for everyone. What do we as a society recommend going forward? I wonder, Dr. Manrique, do you have any thoughts about that with your results?
Yeah, so this is actually a very great question. Doctor is part of our team, and this is something we've been talking about since we found these results. Because I think we have several dilemmas in terms of how to approach this situation. So should we go back and check all the CT scans done in our institution, because this was found incidentally during the ER consultation, right? So should we go back and check all the CT scans? Should we inform the parents? If we inform the parents, what is the purpose of this if we do not know yet what implications we have? So it's an interesting question that we're still trying to find the correct answer, but it would be good to hear like other options and opinions regarding this matter.
I think it sounds like a pretty great collaboration between Dr. Manrique and Dr. Timberlake. Sounds like these kids that are normocephalic maybe need to get sequenced. What you think?
That would be great, yes.
All right, any other comments? Okay, wonderful. So I would like to now introduce our next paper, Bone Tissue Engineering in the Growing Skull, a short-term study using dipyridamole loaded 3D printed beta tricalcium phosphate scaffolds to repair critically sized calvareal defects in a translational animal model, presented by Dr. Evelyn Dimichel Rodriguez from NYU.
Hello, my name is Evelyn Mitchell Rodriguez. Today I will be presenting Bone Tissue Engineering in the Growing Skull, a short-term study using dipyridamole-loaded 3D printed beta tricalcium phosphate scaffolds to repair critically sized calvareal defects in a translational animal model. Here's the source of our funding. Bone is the second most transplanted tissue in the U.S., generating an annual healthcare expense of approximately $2.5 billion. Autologous bone grafting is the current gold standard for the repair of bony defects, but is limited by factors such as the need for a second surgical procedure, donor site morbidity, and high associated costs. Calcium phosphate-based bioceramics such as hydroxyapatite and beta tricalcium phosphate are some of the most common synthetic bone replacement materials. However, their slow degradation rates of only 5 to 10% per year prevent timely resorption, which increases the risk of infection and exposure of graft material and carries the potential to interfere with normal skeletal growth in pediatric patients. Our research group has leveraged 3D printing to manufacture bioceramic scaffolds composed of 100% beta tricalcium phosphate that are biocompatible, bioresorbable, customizable, and can generate bone across critically sized defects that is morphologically and mechanically equivalent to native bone. Dipyridamole and indirect adenosine A2A receptor agonist can be added to these scaffolds to augment their bone regenerative capacity to levels comparable to RHDMP2, another common osteogenetic agent, without causing ectopic bone formation or
he never
bone
I go to
regeneration
school
by
every day. So
PVC
my thing
scaffolds have been
is,
shown to be
he
statistically
leaves 6
equivalent to
o'clock. He
autologous bone
always
grafting in a growing
leave
rat model.
and he
The next step needed to bring
leave
this
me in the
technology
house.
from
And
bench
when
to
he
bedside
comes,
to
usually I am
demonstrate
in the
its
house.
effectiveness
He
in a
never
large translational animal
senses my
model that is
absence.
more similar to humans, such as
So,
pigs.
and
With
also
these
I
goals in
was a
mind,
small,
the purpose of this study was to demonstrate the ability of dippy 3D PVC scaffolds to regenerate bone within critical sized calvareal defects in a skeletally immature pig model and further optimize scaffold design for future studies. 3D PVC scaffolds were created using RoboCAD, a computer-aided design software. 2 scaffold designs were used, one that contained a cap, a solid structure on the ectocortical side of the scaffold used to prevent soft tissue infiltration of the defect site, and one without a cap. A concentrated beta TCP colloidal gel ink was prepared using the listed components and then loaded into a direct ink 3D printer. The ink was extruded in a layer-by-layer fashion onto a stationary platform submerged in a low-viscosity paraffin oil tray to prevent drying. After printing, scaffolds were sintered at 1100 degrees Celsius to eliminate impurities and achieve sufficient mechanical strength. The implants were then sterilized using an autoclave. Before implantation, scaffolds were coated in 1000 micromolar dipyridamole. All surgical interventions received approval from the Institutional Animal Care and Use Committee and were performed using sterile technique. 12 6-week-old Gottingen miniature pigs underwent the surgical creation of full-thickness unilateral calvareal defects using a handheld electric burr. 4 pigs had their defects filled with the scaffolds that had caps, 4 with the scaffolds that did not have caps, and 4 were left empty to serve as negative controls. Sample sizes were determined based on power analyses performed during previously published studies. Implants remained in place for 12 weeks. after which animals were humanely euthanized. After sacrifice, defect sites were isolated using a sagittal saw and subjected to microcomputed tomography. Imaging data was imported into a Mira software for quantitative 3D volume analysis to determine the volume of bone and scaffold in the defect site as a proportion of the total volume of the defect. The volume of bone in the unoperated contralateral side was used to determine the density of native bone. Non-decalcified histological sections were prepared and stained with Stevenel's blue and Van Giesen red stains, which stain soft tissue blue and calcified tissue red, respectively. Samples were evaluated for overall bone morphology, presence of eversion canals, ectopic bone formation, excess inflammatory cells, and suture patency. A generalized linear mix model was performed to determine statistical significance of volumetric analysis. Micro-CT data revealed that none of the negative control group samples had bridging bone form across the defect site, as denoted by the white dashed lines in the top image. In contrast, regenerated bone formed across the defect sites that were filled with scaffolds, as shown by the red arrow in the bottom image. Volumetric analysis revealed that the calvarial defects repaired with scaffolds had an average bone volume of 45.1%, which was significantly greater than the negative controls and approached the density of native bone. Furthermore, the defects repaired with the scaffolds that had caps yielded a significantly greater bone volume of 58.2% compared to 32% seen in the scaffolds without caps. Analysis of remaining scaffold in the defect site after 12 weeks revealed no statistical difference between scaffold design groups. Qualitative histological analysis of the negative control groups showed a lack of bridging bone formation across all defect sites. In contrast, the histological analysis of the defect sites in both scaffold groups revealed vascularized bone that demonstrated intramembranous-like healing with regions of immature woven bone and mature lamellar reorganization, as noted by the yellow arrows in the magnified image. All sutures remain patent with no evidence of premature fusion or disruption, as seen here marked by the purple arrow, and there was no evidence of ectopic bone formation or excess inflammation in any histological samples. This study reports the first evidence of successful bone formation of DIPI 3D PBC scaffolds in a highly translational preclinical animal model. This study has several limitations, including its small sample size and short study duration. Additionally, this model utilized a negative control as a comparison group instead of autologous bone grafting. Long-term studies using this animal model are needed to better elucidate the longitudinal effects of these devices and compare it to standard of care interventions. These experiments are currently ongoing. I would like to thank my collaborators and for the opportunity to present this work. Thank you.
Thank you, Dr. D. Mitchell-Rodriguez. Next, we'd like to introduce Alexandria June from Yale. She's going to be presenting on long-term follow-up of preoperative infant event-related potential in children with craniosynostosis. Dr. June.
The title of this study is Long-Term Follow-Up of Preoperative Infant Event-Related Potentials in Children with Craniosynostosis. The purpose of this study was to determine whether preoperative neural dysfunction in children with craniosynostosis also resulted in poorer neurocognition in those same children years later. Neural dysfunction in infants was measured in this study using a tool called Event-Related Potentials, or ERP. The authors have nothing to disclose. Before moving on, what is ERP? Auditory Event-Related Potentials, or ERP, is a form of EEG, and it's a non-invasive tool for assessing brain activity in infants. They are a recording of neural activity in response to speech sounds and serve as a measure of neurocognition in infants without requiring any overt behavioral response from the infant. Various paradigms can be used, meaning the type of auditory stimulus and the brain waves of interest can differ. ERP studies in infants with autism and dyslexia have been shown to predict future neurolinguistic ability. In craniosynostosis, previous studies have demonstrated abnormal ERP in children with sagittal and metopic craniosynostosis prior to surgical correction. The purpose of this study was to investigate whether these preoperative deficits in neural function persisted into school age. This study began in 2010. 15 sagittal and 18 metopic synostosis patients underwent evaluations of ERP prior to surgery. Two distinct paradigms were administered in order to analyze two waveforms, a mismatch negativity waveform and a P150 peak amplitude waveform. Patients underwent either or both types of analysis. At least 6 years following initial ERP evaluation, patients were contacted for neurocognitive testing. The neurocognitive tests in this study were previously developed in cooperation with neuropsychologists at Yale and consisted of 3 tests: the KTEA3, which measured academic achievement, the WASI-2, which is an IQ test, and the Biri-Bactenica-6, which measured various aspects of visuomotor skills. Because of the previously established relationship between severity of deformity and ERP abnormality in metopic synostosis, this study also sought to determine whether preoperative morphologic severity corresponded with neurocognitive outcomes at school age. Severe morphologic deformity in the metopic cohort was defined as an endocranial bifrontal angle less than 124, and in the sagittal cohort as a cranial index less than 70.7, and these were based on prior definitions in the literature. Correlations between preoperative ERPs and neurocognitive outcomes were assessed using partial Spearman's correlations, controlling for age at the time of ERP. Correction for multiple correlation analyses was performed using a Benjamini-Hochberg test. To assess differences in neurocognitive outcomes based on age at surgery and morphologic severity, we first dichotomized the age into 2 groups, less than 6 months and greater than 6 months, and morphologic severity, less than or greater than the morphologic severity cutoffs just mentioned, and then tested between group differences using 2-tailed t-tests. In total, 13 sagittal and 13 metopic patients completed neurocognitive testing 6 or more years after ERP. Regarding ERP, there were no significant correlations between preoperative ERP and neurocognitive outcome for either paradigm tested in either type of synostosis. There was also no correlation between preoperative morphologic severity and neurocognitive outcome for the sagittal or metopic groups. However, when stratifying neurocognitive outcomes by age at surgery, patients who received surgery at less than 6 months had higher scores across the board and significantly higher scores in full-scale IQ, 109 versus 95, visual motor integration, 103 versus 90, and visual perception, 106 versus 96. In conclusion, our results did not find a correlation between degree of presurgical neural abnormality and eventual neurocognitive outcome. Thus, our results suggest that the degree of presurgical deficits in neural activity does not correspond with the degree of postoperative neurocognitive deficits. Rather, our results suggest that the preoperative processing deficits that arise as a result of the constriction on the brain from the overlying fused suture may be ameliorated if corrected early enough. Our results corroborate the work of prior studies demonstrating a relationship between earlier age at time of surgery and improved neurocognitive functioning later in life. They also suggest that age at surgery may play a greater role in eventual neurocognitive function compared to severity of deformity at time of surgery. Thank you for giving us the opportunity to present this work today. Particular thanks to Dr. Michael Alperovich and Dr. John Persing, who guided and supported this work, as well as members of the Child Study Center and Plastic Surgery Department at Yale, without whom this study would not have been possible.
Thank you, Dr. June. Wonderful presentation. Our next paper, Prenatal Diagnosis of Pierre Robin Sequence Using Ultrasound, will be presented by Raisa Islam from the University of Pittsburgh.
Good evening, everyone. My name is Raisa Islam. I'm a 4th-year medical student from Pitt Med, and today I'll be presenting on prenatal diagnosis of Pierre Robin sequence using ultrasound. I have no disclosures. PRS is currently diagnosed postnatally, and although it is a rare disorder, the mortality rate is reported to be as high as 30%. If we were able to make it a prenatal diagnosis, it could be key in preparing the delivery team for an airway emergency and thus minimizing prolonged hypoxia. Shown here is a 20-week anatomy ultrasound, which provides anatomical measurements. However, none of these include measurements for micrognathia. That being said, it's really obvious that you can see the maxilla bone and the mandible bone. These are two bones that we can use to create parameters for micrognathia. What we decided to do was create a case control study design. First, we had infants born at McGee Women's Hospital between 2009 and 2019 who had PRS, and we linked them to mother's charts to find the 20-week anatomy ultrasounds. Then we were able to find controls or babies without PRS and link those babies to the mothers, assuming that they also had 20-week anatomy ultrasounds. Then we went back and we collected measurements for 3 different parameters to analyze signs of micrognathia on ultrasound. So what were these parameters? First, we have FMA, or facial maxillary angle. Anything less than 66 degrees is what we deemed micrognathic according to literature. And this line is created with one line from the mandible that overlies the lips, and the other line is going straight across the maxilla bone. Second is FNMA, or facial nasomental angle. This is an angle that's created with the vertex at the tip of the nose, with one ray going back across the frontal bone and the second going down towards the mandible at the very most protuberant part of the chin. And third is alveolar overjet. This is a novel measurement, so I'll talk about this a little bit more in depth. Alveolar overjet is a measurement that people can make postnatally typically, and it's used in clinic all the time, but it's never been done prenatally or used in ultrasound literature. And so on the left here, the line that's marked with the number 1 is the Frankfurt horizontal. This is a line that goes from the most inferior portion of the orbit back towards the ear, typically the most, the external auditory canal. And if you can notice here, this is pretty parallel to the maxilla bone. So what we decided to do is recreate the Frankfurt horizontal on a mid-sagittal image of a fetus. And we made it so that it was pretty parallel to the maxilla bone here. Then we created 2 lines that were perfectly perpendicular, one that aligned with the most anterior portion of the maxilla bone, another that aligned with the most anterior portion of the mandible. And then the distance between the 2 is what we deemed alveolar overjet. For our results, we had a total of 48 patients with PRS who were born at McGee Women's Hospital, who were matched for both gender and race to 48 controls. We ended up with 29 males and 19 females in each group. And we also assessed for inter-rater reliability between 2 readers. And all of our values for reliability were above 75%. So going from left to right, first we have FMA. The blue line demarcates the cutoff for micrognathia, so anything less than the blue line is micrognathic. You can see that there was a significant difference between the PRS group and the control group, in that the PRS group had a severely more acute angle for FMA. And the same exact thing applies for FNMA. Both, it was also severely more micrognathic or acute for the PRS group. And then lastly, for alveolar overjet, there is no blue line, no cutoff, because this is a novel measurement. However, looking at this graph, you can tell that it is significantly different between the PRS group and the control group, and that the cutoff could be somewhere between 2.5 to 3.5. So to conclude, it is possible to quantify the maxillomandibular relationship on prenatal ultrasound. Alveolar overjet, previously not described in prenatal ultrasound literature, is both measurable and could have utility in prenatal diagnosis. And for future directions, we'd like to increase our sample size as our biggest limitation right now is lack of power. Thank you.
Thank you, Dr. Islam. If the last three presenters would now turn on their cameras, I'd like to open this up to the attendees for question and answers. Please feel free to offer any questions and we'll relay these to the speakers.
We have a question from Dr. Buckman. Could delay in diagnosis because of health issues or social issues give a bias as to worse neurocognitive issues on children operated later? Those that are sicker and worse situations would be expected to do worse, and they would also be expected to have delayed presentation and surgery.
The other abstract authors do not appear to be on the call this evening.
Okay. So we'll move on to Dr. O's question. Upper airway obstruction in Robin sequence is not purely anatomic. What do you recommend in patients with syndromic patients with hypotonia or systemic issues? Wait, is that?
Justine, can I speak to Buckman's statement? I just because he had such a wonderful response in the chat room. The other option is that maybe the people who are sicker actually get examined earlier. And sort of the in-between people, I would think, would be the ones who would be delayed in getting care. Because people can recognize something really abnormal. I'm just putting it out there, but I don't have data related to whether the timing of initial evaluation was worse with the sicker or the less sick, but I just wonder whether that's a factor.
Well, I see Dr. DeMitchell Rodriguez here, so I have a question for you. I always love the work coming from your group on dipyridamole. I was wondering for this one, how do you distinguish between your beta TCP versus regenerated bone? Is there any sort of condition or way that you would section your micro CT scans that would separate that out?
Thank you so much for your question. So for this study, the scaffolds themselves were dipped in dipyridamole right before they were implanted in the animals. So when we see the micro CT imaging, we can separate out based on Hounsfield units in Amira software that we use to reconstruct and visualize the 3D structure of the defect with the scaffold and regenerated bone. We can change the thresholds of this software based on different Hounsfield units to be able to see what is regenerated bone versus remaining scaffold.
Mm-hmm. And this might be something you may or may not have, and that's a great answer. You may or may not have an answer to that, that's okay. But do you happen to know how stiff it is? Like what's the elastic modulus of your scaffold?
That is a great question. We actually did not do nano indentation for my specific study. They have done nano indentation in the past, and I apologize, but I don't know those values offhand. But all of the regenerated bone in the past studies that have been published from this group has been statistically equivalent to native bone when they've compared the stiffness and elastic modulus between them.
Great answers.
Thank you.
I don't see any more questions in the chat box.
All right, we'll keep moving then. We will now be hearing quick shot presentations in the main room. There will also be a breakout room for mentorship where we'll be able to meet the PRC Executive Committee and how to get involved with Drs. Borschel, Gassman, Green, Snyder, Warwick, and Wong. And they'll be able to open that up now, so please join those. For those of you who stay in this room, we'll get going here in a few seconds.
Everyone should have seen a pop-up to join the breakout. You can go ahead and click on that. Or at the bottom of your Zoom window, you can click on the breakout box. If you do not see that box, click on the 3 dots that says more, and the breakout should be below that. If that still doesn't work, you can send a chat message directly to Pete LaCour, and I can assign you into the room. Thank you.
All right, well, we'll get started with the quick shots for those of you who are still staying in this room. Our first presentation will be nasopharyngeal airway and subcranial space analysis in Pfeiffer syndrome. And this will be presented by Dr. Liu from Yale University in New Haven. Dr. Liu, you're up.
Nasopharyngeal airway and subcranial space analysis in Pfeiffer syndrome. Airway anomalies occur in almost all patients with severe Pfeiffer syndrome. Although tracheotomy can effectively improve respiratory compromise, difficulty in decannulation follows as another problem for those who survive. One reason for this difficulty is inadequate correction of the anatomic structure of the nasopharyngeal airway. In this study, therefore, we have investigated the regional anatomy of the nasal and pharyngeal airway in patients with Pfeiffer syndrome to provide insights into the potential airway obstructions and prepare for later decannulation. Preoperative CT scans of patients with Pfeiffer syndrome, along with age and gender-matched normal individuals controls, were included. The measurements include nasal and pharyngeal airway volume, cross-section area at 4 levels of respiratory passage, and subcranial dimensions. We observed the patients with Pfeiffer syndrome developed a 50% reduction in nasal airway volume and a 44% reduction in pharyngeal airway volume compared with controls. The cross-section area at the corona was less than half that of the controls. The cross-section area at the congenital and gonial levels, which indicate the caliber of pharyngeal airway at the entrance and midsection, were reduced by 67% and 47% respectively compared to the controls. The reduction in the cross-section area at hyperpharynx at the level of the third cervical vertebra reduced by 30% in the patients who are younger than 3 months of age. The distance from the posterior nasal span to the sella, indicating the height of nasal passage, reduced by 21%. The distance between bilateral medial and lateral pterygoid plates were shortened by 14%. The 16% shortened distance between the basal and anterior nasal span indicates there is a significant reduction in the anterior posterior length of the nasal passage. The anterior posterior length of the pharyngeal roof entrance reduced 16%, along with a narrower pharynx. So to conclude, the volume of the nasal airway in patients with Pfeiffer syndrome is significantly restricted in length, height, and width. Shortened maxilla contributes more to the reduced anterior posterior length of the nasal airway than its posterior position. Structural restrictions of the pharyngeal airway across the entire course of the pharynx. Therefore, medial-lateral maxillary expansion, in addition to maxillomandibular advancement, is likely to benefit patients with Pfeiffer syndrome with respect to improving the structure of upper airway and later decannulation.
Thank you, Dr. Liu. Our next speaker is Helen Shun from Johns Hopkins School of Medicine in Baltimore, and she will be presenting the next quick shot entitled The Underreporting of Traumatic Brain Injuries in Pediatric Craniomaxillofacial Trauma, a 20-year retrospective cohort study.
Hi everyone, my name is Helen Chen and I am a medical student at Johns Hopkins, and thank you to PSRC for the opportunity to present. These are our relevant disclosures. Craniomaxillofacial trauma is often complicated by traumatic brain injuries, which can impact timing and planning of operative repairs. Despite these adverse outcomes, 46% of TBIs remain unrecorded, correlating with less likelihood to be referred for follow-up visits. Furthermore, little is actually known about pediatric populations who are anatomically susceptible to both CMF and TBI injuries. Due to the paucity of data in the pediatric populations, the objective of this study is to characterize the subpopulation of concomitant TBI and CMF pediatric trauma patients. The specific aims is to be the first study to establish and characterize a cohort and determine chart documentation. To achieve this, we performed an IRB-approved retrospective cohort study to the Johns Hopkins Hospital over 20 years. Charts were reviewed for CMF trauma patients with TBIs and compared to non-TBI CMF patients. Of the 2,966 pediatric CMF trauma patients, the frequency of concomitant TBI was at 27%. Patients were significantly more likely to be male, suffered from blunt injury, and had lower ISS and GCS scores at presentation. Facial fracture patterns also differed. CMF trauma patients with TBI were more likely to have upper third fractures and combined fractures, and less likely to have midface fractures. Of note, CMF with TBI patients had longer lengths of stay and almost double the mortality rate at 2 years compared to patients without TBIs. The severity of TBI itself significantly correlated with increasing mortality rates, longer lengths of stay, and time to follow up. But despite the significant impact of TBI on patient outcomes, documentation was poor. Only 1.6% of charts contained the phrase traumatic brain injury. So in summary, the frequency of TBI in pediatric CMF patients is significantly higher than adult populations. Patients often have worse outcomes, and cases are very poorly documented. So our preliminary results suggest that CMF and TBI is underrecognized, underdiagnosed, and potentially undermanaged. So how can your practice change based on these initial findings? Even mild TBIs have been known to have long-term life-altering consequences, but are often missed in kids. So providers should screen high-risk pediatric CMF trauma patients for TBI. Future work includes developing screening guidelines for early diagnosis, documentation, and management. Despite the limitations of a single-center retrospective study, our preliminary results generate many questions and hypotheses for future studies with the potential to change patient practice and care. Thank you so much for your time, and I would like to thank my co-authors, including Dr. Chris Lopez and Dr. Joseph Lopez.
Thank you for that presentation. Our next paper will be Influence of Non-Syndromic Bicoronal Synostosis and Syndromic Influences on Orbit and Periorbital Malformation. It'll be presented by Dr. Liu, again from Yale University.
Influence of non-syndromic bicoronal synostosis and syndromic influences on orbit and periorbital malformation. Ocular orbit disproportion in patients with cranial synostosis has similarities and dissimilarities between syndromic and non-syndromic cases. We hypothesize these two conditions have specific individual influences as they related to development of the orbital and periorbital skeletons. In this study, therefore, we compare orbital and periorbital morphology in non-syndromic bicoronal synostosis to normal controls in order to explore the independent influence of this isolated cranial vault suture on orbital facial development. We compare the added influence of two cranial synostosis syndromes with isolated bilateral cranial synostosis to investigate the unique influences of these syndromes' pathologies. Preoperative CT scans of 133 patients with non-syndromic and syndromic bicoronal synostosis and matched normal individuals as controls were included. We observed that orbital cavity volume is mildly restricted in non-syndromic bicoronal synostosis, along with a reduced global volume and increased global projection volume. The orbital cavity volume was further reduced in syndromic patients, and the APER syndrome patients developed more reduced global volume. The global projection volume increased more than a half in Coulson syndrome compared to isolated bicoronal synostosis cases. Non-syndromic bicoronal synostosis develop a 9% shortened orbital roof and a 5% shortened orbital floor, while APER syndrome further shortened the orbital roof by 5%, and Coulson syndrome further shortened the orbital floor by 10% when compared with non-syndromic. Non-syndromic bicoronal synostosis does not limit the maxillary length, but causes maxillary retrusion. Apert syndrome resulted in maxillar hypoplasia, while the maxillary position was more rotunded in Congenital syndrome. To conclude, orbit and peri-orbit malformation in patients with syndromic cranial synostosis are likely the combined consequences of the syndromic influences and concurrent cranial vault suture synostosis. Apert syndrome patients require more expansion in the maxillary bone to advance maxillary profile forward, while Congenital syndrome patients conceptually require more advancement of the maxillary position rather than expanding the anterior posterior length of the maxillary bone.
Thank you, Dr. Liu. Our next presenter is Rama El-Nagi from the University of Detroit Mercy in Detroit, Michigan, and she will be presenting on a quantitative analysis of the upper airway morphology in patients with attention deficit hyperactivity disorder, a cone beam computed tomography study.
Hello, thank you for joining us in this session. Our research is a quantitative analysis of the upper airway morphology in patients with attention deficit hyperactivity disorder. The aim of the study was to evaluate the upper airway morphology of adolescents with ADHD compared to controls. This is a retrospective comparative study where the total sample was 87 adolescents, of which 29 patients were allocated in the ADHD group and 58 in the control group. The inclusion criteria was adolescents diagnosed with ADHD with full pretreatment orthodontic records, including CBCTs. CBCTs were oriented in all three planes of space. Dolphin 3D software was utilized to identify the upper and lower limits of the airway space, then planes A to D were determined. And the airway volume acquisition was completed through Dolphin 3D Sinus Airway tool. A demonstration of the cross-sectional area acquisition, length, and width of all four planes is shown in these figures. Statistical analysis was performed to compare the airway data between the two groups. And the overall means of airway volume and minimum axial area in the ADHD group were smaller than the controls, but the difference was not significant. There were significant differences in the airway widths at plane A, C, and D, and in the airway area at plane D, with the ADHD group showing narrower widths and area compared to the control. The significance decrease in width would be attributed to the concept of physiologic adaptation, in which the airway length would change in size in order to compensate for the narrowing in width, merely to maintain survival. The evaluation of the upper airway included volumetric, minimal, cross-sectional area, and linear measurements in different planes of the airway. This represents a point of strength of the study. The study had some limitations, such as not accounting for the body mass index and recruiting the sample from a single institution. So we conclude that the upper airway volume in the ADHD group showed lower values when compared to the control group. The differences, however, were not statistically significant except for the airway widths at planes A, C, and D, and in the airway area at plane D, representing a more constricted airway among patients with ADHD. Further investigations with larger samples are warranted to further evaluate the upper airway morphologies in individuals with ADHD. These are some of the references that have helped us conduct our study. Thank you for your time. I hope our project was beneficial to you. Please don't hesitate to contact us if you have any questions.
Thank you. Hey, Justine, I'm having a little technical problems on my list of next speakers. Can you help me on who is next? Oh, actually, I think I've got it now. It's Dr. Malapati from UCLA, and the discussion is going to be on pharyngoplasties associated with long-term sleep-related impairment in patients with cleft palate.
I'm Harshini from UCLA, and this work is looking at pharyngoplasty and its association with long-term sleep-related impairment in patients with cleft palate. No disclosures. It's estimated that 11 to 50% of patients who are born with cleft palate develop velopharyngeal insufficiency, or VPI. VPI prevents the velopharyngeal port from completely closing during swallowing or speech, which can lead to food regurgitation and hypernasal speech. One of the surgeries used to correct VPI is sphincter pharyngoplasty, which decreases the size of the nasopharyngeal airway, increasing the risk of developing obstructive sleep apnea or OSA symptoms. Multiple studies have already examined the short-term effect of pharyngoplasty on OSA symptoms within a 5-year post-op period, but the long-term impact is not known. Polysomnograms are the gold standard for diagnosing OSA, but they're not cost-effective, and they're also resource-limited for screening. In our study, we aim to use validated patient-reported outcomes measures to look at the effect of pharyngoplasty on the development of OSA symptoms in the long term, specifically looking at patients who are over 14 years old. 61 cleft palate patients over the age of 14 were prospectively administered a patient-reported outcomes measurement information systems, or PROMIS, sleep-related impairment short form, which has been nationally validated. We conducted retrospective chart review to collect patient demographics, surgical, and past medical data. Our data shows no significant differences in sleep-related impairment scores by these factors that could potentially be affecting sleep. We found that there was a significantly increased sleep-related impairment in patients who were diagnosed with WPI compared to patients without WPI. Specifically, we found that patients with a history of pharyngoplasty had significantly increased sleep-related impairment compared to those without pharyngoplasty. No significant differences were found in other surgeries affecting the airway. Among patients with pharyngoplasty, no significant differences in other surgeries that could potentially be acting as confounding factors. In conclusion, pharyngoplasty among patients with cleft palate is associated with increased sleep-related impairment even after the age of 14 years. Even though pharyngoplasty cannot be considered to be a cause of long-term OSA, our current study suggests that increased vigilance in long-term validated quantitative sleep screening may be important for patients with pharyngoplasty with potential considerations for intervention. It should be noted that as a limitation, the PROMIS Sleep Survey examines sleep-related impairment and does not directly look at OSA diagnosis. Also, for future directions, surveys on psychosocial outcomes affecting sleep should be administered to account for potential confounding factors.
Thank you, Dr. Malapati. Our next speaker is Kelly Huang from the Division of Plastic and Reconstructive Surgery at UCLA, and she'll be presenting on developing the psychosocial growth chart, prospective longitudinal psychosocial functioning of children with craniofacial anomalies.
Hi, I'm Kelly Huang from UCLA, and I'll be talking about our work on developing the psychosocial growth chart, which is a prospective longitudinal study on the psychosocial functioning of children with craniofacial anomalies. We have no disclosures. Our research group found in a previous cross-sectional study that children ages 8 to 10 with craniofacial anomalies are at increased risk for psychosocial distress. Moving forward, longitudinally charting psychosocial development may be important for establishing psychosocial functioning as a measured health outcome. In this study, we aim to evaluate the longitudinal psychosocial development of the original cohorts for 6 years. In our first younger cohort, 23 children with craniofacial anomalies were longitudinally assessed at both ages 8 to 10 and ages 11 to 13. Meanwhile, in a separate older cohort, 32 children were surveyed at both ages 11 to 13 and 14 to 17. Psychosocial functioning was prospectively evaluated using the validated patient-reported outcomes measurement information system to assess anger, anxiety, peer relationships, and depressive symptoms. In the younger cohort, children with craniofacial anomalies demonstrated a significant decrease in anxiety as they progressed from ages 8 to 10 to ages 11 to 13. Meanwhile, in the older cohort, children demonstrated a significant increase in anger and depressive symptoms as they progressed from ages 11 to 13 to 14 to 17. Taken together, our findings show that from the high-risk ages 8 to 10 to ages 11 to 13, children with craniofacial anomalies demonstrate an increase in psychosocial functioning. However, from ages 11 to 13 to 14 to 17, children with craniofacial anomalies demonstrate a decrease in psychosocial functioning. The current study serves as a pilot study to develop a psychosocial growth chart that may be incorporated as a standard of clinical care. A few limitations of this study is the small sample size and that data was collected from a single tertiary care multidisciplinary clinic. Future directions include conducting larger longitudinal multi-center studies and identifying demographic and clinical factors associated with increased psychosocial dysfunction over time to identify higher risk subsets. I would like to thank my team and our mentor, Dr. Justine Lee, as this project would not have been possible without them. Thank you so much for listening, and please feel free to contact me if you have any questions.
Thank you. Our next presentation will be by Dr. Matt Pontel from Vanderbilt University, and it'll be titled Resorbable versus Titanium Rigid Fixation for Pediatric Upper and Midfacial Fractures, a Systemic Review, Institutional Experience, and Comparative Analysis.
Pontel, and thank you for the opportunity to present at the Plastic Surgery Research Council's 2021 virtual meeting. The title of our study is Resorbable versus Titanium Rigid Fixation for Pediatric Upper and Midfacial Fractures, a Systematic Review, Institutional Experience, and Comparative Analysis. The authors have no relevant financial disclosures or conflict of interest. Pediatric facial fractures requiring open reduction and internal fixation are rare. Improperly treated pediatric facial fractures can result in poor aesthetic and functional outcomes, which translates into a high risk of needing corrective orthognathic surgery later in life. Risks inherent to titanium metal have led to increased interest in resorbable hardware, but data comparing the two types of hardware is scarce. This study aims to compare the risk of titanium and resorbable hardware systems when used for the ORIF of pediatric upper and midfacial fractures. A systematic review was conducted, and studies were included if published between 1990 and 2020 and reported outcomes of ORIF of traumatic pediatric upper and midfacial fractures. Using the same criteria, a retrospective review was conducted at Monroe Carroll Jr. Children's Hospital, which is a regional level 1 pediatric trauma facility. 23 studies met inclusion criteria, yielding 659 patients, which were combined with 77 patients from the institutional review, yielding a final cohort of 736 patients. 59.4% of patients underwent ORIF with titanium hardware compared to 40.6% of patients who underwent ORIF with resorbable hardware. For each study systematically reviewed, the mean age was 16.3 years or less. However, patient ages, genders, and mechanisms of injury were inconsistently available for patient-by-patient abstraction. In both groups, patients were more frequently treated by ORIF only. The complication rate was significantly higher in the titanium hardware group. However, complications requiring intervention were not significantly different between both groups. Almost 90% of patients required elective hardware removal, which required a second surgery in the titanium group. Additional analysis was then performed to determine if there was an association between fracture type and complication rate. Within the resorbable group, there was no specific fracture that increased the rate of complications. However, in the titanium group, the treatment of maxillary fractures significantly increased the rate of complications. Complication rates were then compared between groups at each fracture site. Complications were significantly higher when maxillary fractures were treated with titanium hardware compared to resorbable hardware. Titanium hardware historically remained the standard of care for ORIF of such fractures. However, the results of this study demonstrate that the rate of complications is lower with resorbable hardware. Additionally, almost 90% of patients underwent a second surgery for titanium hardware removal. The use of titanium also appears to have a further increased risk when utilized for the treatment of maxillary fractures. While the study sheds insight into the treatment of pediatric facial fractures, there is a dire need for powered prospective comparative studies. Thank you for your time.
Thank you, Dr. Pontel. Our next quick shot will be decellularization of vascularized composite allografts in the rat, presented by Elise Lupon from the Vascularized Composite Allotransplantation Laboratory, Center for Transplantation Sciences, Mass General Hospital, Boston, Mass.
Hi everyone, I'm Elise Dupont. I'm a research fellow at Mass General Hospital and a French resident in plastic surgery. The main limiting factor for vascularized composite allograft use, or VCA, remains a lifelong immunosuppression treatment to avoid transplant rejection. The decellularization of composite vascular tissue allograft (VCA) represents the first step in avoiding the need for immunosuppression by depleting donor cells from VCA. This study aims to decellularize rat limbs by removing all cells from the graft. Rat limbs, based upon the common femoral artery, were harvested from living rats under general anesthesia and then flushed with heparin. Using a pressure control device linked to a pump, the grafts were perfused with SDS 1% or 0.2% for 5 days or just immersed in the solution. And then it was treated with a second detergent, Triton 1% for a day. The degree of decellularization was assessed by gross appearance and quantitatively by determining DNA content in all groups at the same location. The group yielding best decellularization outcome was selected for further assessment for preservation of the extracellular matrix content and vasculature and was transplanted in vivo. We have observed the present morphology of the grafts, but only completely white in the group SDS 1%. DNA content was below 50 nanograms per milligram of tissue in the group decellularized with a concentration of SDS 1%, which means it was decelled. The properties of the extracellular matrix were assessed and show an increase of the collagen content in the muscle and a preservation of the glycosaminoglycan content. Vascular patency, assessed by imaging, showed a preserved vasculature post-decellularization. The arterial networks was found to be perfusible and intact during in vivo orthotopic transplantation of the decellularized gland. However, no outflow was observed after 2 hours of arterial reperfusion. So, we described a successful decellularization protocol for rat and lamb BCAs by perfusion ex vivo of 1% SDS. During its in vivo transplantation, decellularization allows for a perfusible arterial networks, and with further optimization, we aim to achieve venous perfusion as well. Thank you very much for your attention, and I would like to acknowledge my team.
Thank you, Dr. Lupon. The final paper in the quick shot session is Micro Nanobubbles, a novel fat graft enrichment technology presented by Faris Halaseh from Center for Tissue Engineering, University of California, Irvine in Orange, California.
Irvine. I would like to thank PSRC for giving me the opportunity to present. And today I'm going to be speaking about MNBs, a novel fat graft enrichment technology. We have no conflicts of interest. Fat grafting remains one of plastic surgery's most commonly performed operations. However, a major limitation to this technique is the variation of retention rates. This is controlled by the amount of oxygen that is available to adipose tissue, which is ultimately dependent upon a blood supply. At UC Irvine, we have discovered a new technology known as micro nanobubbles, or MNBs, which are extremely small gas-carrying bubbles in the low micro to nanosize range that are made with saline under turbines. Microbubbles become nanobubble over time, allowing them to be internalized by cells. The MNB solution is highly concentrated, and these bubbles can persist for hours to months depending on how they're formed. Finally, solutions with MNBs carry up to 800 millimeters of mercury worth of oxygen, which is 5 times the carrying capacity of water. To assess fat graft survival, we obtained human lipoaspirate and washed the tissue in either saline or saline with MNBs, removing excess blood after centrifugation. 12 nude mice were randomly assigned to 2 groups, either a saline wash or saline with MNBs, and each mouse received 4 dorsal implants of the washed lipoaspirate. We assessed graft viability for the MNB and saline washes at 4, 8, and 12 weeks, sacrificing 2 mice per group at each time point. The grafts were weighed and harvested tissue volume was assessed using a gas pyknometer. We also ran CD31, CA9, and perilipin immunohistochemistry. We assessed angiogenesis via CD31 staining. The vessel density was significantly greater for the MNB group, suggesting improved angiogenesis in the grafts with MNBs. And ANOVA also suggested that with increased angiogenesis, we saw a larger graft volume in the MNB group over the course of 12 weeks, demonstrating that MNBs improved graft retention. Next, to assess de novo adipogenesis, we used an antibody showing specificity for mouse perilipin and conducted immunohistochemistry. At both 4 and 8 weeks, the level of adipogenesis was greater for the MNB group. Finally, the CA9 staining shows that MNBs reduce hypoxia at 4 weeks, meaning that they can combat the initial hypoxia associated with cellular transplantation. Taken together, these data suggest that oxygenated MNBs can improve graft retention, increase vessel formation, upregulate adipogenesis, and prevent hypoxia. We believe that this new modality for improving tissue oxygenation will revolutionize lipotransfer in the future. Thank you so much for listening.
Thank you, Dr. Hallisey, and to all of our quick shot presenters. We now should have everyone back from the breakout room. We'll be ending this evening with a panel discussion on neuropsychological outcomes in non-syndromic craniosynostosis. Our first panelist is Dr. John Persing from Yale Plastic Surgery, New Haven, Connecticut, speaking on cognitive changes in the treatment of craniosynostosis, a deeper dive into the data.
Hi, can you hear me?
Yes, we can.
Great. What I'm going to ask is the slides be presented as a note that they need to be advanced, if that's okay with you guys. I can't seem to put that together right now. I'm going to talk, if we go to the next slide, about sagittal synostosis just because of its prevalence, and also it's been discussed quite a bit more frequently than other forms. The next slide, please. Sagittal synostosis I sort of ran into when I moved to New Haven because the previous group there had been doing a lot of strip craniectomies, and I hadn't really had a lot of experience with that. Did some, but not a huge number. And I was struck by, next slide, please, by the discussions with the parents. Next slide, please. With the parents of these people, the young kids who've been operated on, that although their IQs were measured as being normal, they're really not doing well in school. They had they had problems with attention and also achievement, and the families were very upset about it. So we did a little study on these kids to see what they're doing from a more comprehensive neuropsychological perspective, and found that instead of the 5% learning disability anticipated in the general population, there were about a 45% increase, a 45% incidence of neurodevelopmental problems related to learning disabilities. Next slide. It was kind of interesting enough so that I thought maybe we ought to spend a little bit more time looking at neurocognitive things. Next slide, please. And we are clearly not the first people who are involved in this. We have to take our hats off to Dominique Grenier and Daniel Marchak for the fact that they were doing that in Paris, doing intracranial pressure measurements by putting bolts in the heads of kids with craniosynostosis, keeping them in the ICU, measuring their ICP, and also doing IQ testing. Next slide, please. The interesting thing was that they did find that if we just look at scaphocephaly again, limiting ourselves to sagittal synostosis, that if you operated on these kids less than a year of age, they did very well. And if you waited longer than that time period, they had a statistically significant reduction in people having a normal IQ. That seemed to be very, next slide, very interesting to me. But when I was talking to the two related to how they were doing their measurements early on, they said they were doing IQ tests as early as a year of age. And I said, well, how do you do that? Anyway, they proposed that, rather they said that they were doing what is called a developmental quotient, which is actually a test that was developed at Yale, and a really understanding of its limitations as well as its benefits. In other words, it really was not predictive of long-term future. And that's kind of an important concept, because if you're making assessments based on what somebody is doing in early stages of life, and you're outlining a plan for their treatment, you would hope that it would be sort of consistent all the way through, meaning that if they had a problem at the beginning, they would have a problem later on, and therefore it's worthwhile doing something from an interventional standpoint. On the other hand, if they were doing poorly, you would be able to, if they're doing poorly, you wanted to intervene for them. If they're doing well, you want to leave them alone. Next slide, please. So out of that, we got to this point where we started looking at the timing and type of surgery to see whether that had any influence. Next slide, please. There are two major groups. One is the sort of the whole vault cranioplasty group. There's advocates for that because it is more comprehensive and it is done, but has the disadvantage of more blood loss and more expense, I would assume. On the other hand, next slide, please, the more localized endoscopic approaches were very appealing because they were shorter procedures, ostensibly less risk, and less cost. So we use that two broad frameworks to look at from the standpoint of what seemed to be the better way to go. Next slide, please. But we also recognize that it's not just a one-size-fits-all assessment, that there are many factors that are involved in intellect, and it's not just whether you had a surgical procedure or not. So we wanted to look at what's called propensity factors. Next slide, please. And basically, these could be confounding factors such as socioeconomic status, parental educational level, and the severity of deformity. And these, amongst many other things that we looked at in trying to make these assessments as to whether there are limitations to the surgery or not. And we also wanted to make sure it was adequately powered, and that was assessed at a 0.8 level for all the studies that we followed with. Next slide, please. We excluded people for assessment when they had an IQ less than 70. For the genetic things that you heard Andrew Timberlake talk about a little bit earlier, and I'll get to hopefully, if time permits, a little bit later. Next slide, please. The initial results were, this is a study where we were assessing kids who had either a craniovault or whole vault cranioplasty done less than 6 months of age to kids who had a strip craniectomy approach. And just tried to make some comparisons as to how they were doing. Although both of them had IQs greater than 100, there seemed to be a higher scoring for the kids who had the whole vault cranioplasty. Next slide, please. And that was also true for achievement. You could see that there were significant changes in favor of going through the whole vault cranioplasty approach, as opposed to the strip cranioplasty approach. Next slide, please. And not surprisingly, learning disabilities were also higher in the strip craniectomy group as opposed to the whole vault group. Next slide, please. So it was appropriate. I was asked about this. Well, this really isn't the best way. We should look at it from a different viewpoint, in that strip craniectomies, to be maximally effective, are usually done less than 3 months of age, and that's what we should be looking at compared to the best approach for the whole vault cranioplasty group, which was, we were saying, less than 6 months of age. So when we did that, however, it was clear that the regularities were still persistent. There was a statistically significant difference, although it was not a huge one, between the whole vaults and the strip craniectomies in favor of the whole vault cranioplasty, even when the craniectomy approach, linear craniectomy approach, was in just taking those children who had the procedure under 3 months of age. Next slide, please. So we basically got a consistent statement that basically the improvements were more apparent in the patients who underwent whole vault cranioplasty than those who had a strip craniectomy. Next slide, please. So the further concern was raised by a group at Boston Children's that in reality, you're not looking at kids who have the strip craniectomy. The group that we had enlisted early on, the University of Pittsburgh, were doing also some cuts into the parietal bone and also cinching the skull front to back at the region of the anterior fontanelle. And in reality, that's not really an appropriate comparison. So we should just do those with linear craniectomy. Next slide, please. So we repeated that, and basically we're using the exact same evaluation methods. The only difference was that we were looking at patients who were done at Boston Children's who did not have any other intervention, and it was just a strip craniectomy. Next slide, please. And basically, we wound up with the same results. The story was still in favor of the patients who underwent a full vault cranioplasty as opposed to ones with just a linear craniectomy alone. So next slide, the questions came back, well, then maybe you've got a skewed population at Yale. The IQ is just too high to make this a reliable test. Next slide, please. So we said, okay, we'll look at it from a different viewpoint then. We'll cut out the kids who have an IQ greater than 120 to get rid of the superstars, that is. And then we would do only patients who had less than 120, but greater than 70. And next slide, please. And we got the same sort of return, though, basically that they still had, in terms of achievement, better performances in reading comprehension, spelling, and numerical operations, sort of consistent with it when we're not really measuring differences in IQ. Next slide, please. So then the next statement was, well, there are other factors such as educational levels of parents and socioeconomic status, et cetera, that could be contributing to this bias. And maybe that was still the reason why in a Haven group are doing a little bit different than those being done at Boston Children's. Next slide, please. Well, it was true that there was a difference, but the difference was in favor of the group having the strip craniectomies. In other words, socioeconomic status was and educational level were higher actually than the strip craniectomy group. So that was not an answer. Next slide, please. So we have not found a perfect study, nor have I ever seen one, but in reality, I have no problem with more studies being done similarly to this type of study. And in fact, trying to clarify this for others if this is a more pressing question in terms of defining what you're going to recommend to your patients. Next slide, please. So what about springs? Basically, I'm going to make this quick because I think I'm running out of time. This will be the same sort of thing. Next slide, please. The work was brought up as a feature of something we were doing in the laboratory in the 1980s. Next slide, please. And Mike Alperovich and Lisa David did a wonderful job in doing a study similar to what we did before with the other groups. Next slide, please. And did all the compensatory, all the other influencing factors, trying to mitigate those as well by making them equal. And again, the same sort of outlook that the Craniovault group did better than the Spring group. And this again, a consistent history that you got to do things early and quick and well in order to get the maximal effect. Next slide, please. Next slide. I'll just go ahead because it's sort of the same thing. Next slide again. So there are some trade-offs going ahead with early surgery. Next slide, please. This is brought up by people I respect, Jeff Farron saying, well, you ought to hold off until after 10 months of age in order to do surgery, so you don't have to do a repeat surgery, because oftentimes very young patients will wind up having to have their surgery repeated. Next slide, please. So we basically went through the same sort of review of things. So we looked at some patients. Next slide, please. To look at kids who were operated on at early stage of life and then had to have a reoperation, as opposed to people who didn't have a reoperation, to see whether there was any difference between those two groups. No, and you can see there's really no difference. Okay. I don't know where we are now. Can I go back to the slide, or is that okay? So now the next step is we wanted to look at people who did have a reoperation and see whether that was different than the patients who had delayed surgery. Next slide, please. So again, the question is it greater than, if you wait 6 months, maybe we could get a bit better outlook. Next slide, please, because you didn't have to have that second operation. But we were surprised to find that it was not the case. In fact, if you waited until after 6 months of age, you actually had poorer outcomes in terms of IQ than you had with patients who had a reoperation if they had their first operation before 6 months of age. Next slide, please. Well, again, this is the same thing was true for the achievement learning and learning disabilities issues as well. Next slide, please. So this all pertains to sagittal synostosis, as I said. It may be different from METOP or coronal or this or that, but this is what we have the data at least to work from today. Next slide, please. So the reasoning, though, you could say is, well, what the heck? This is, you're doing later reoperative surgery, and if there is a previously early surgery, there is no decrement in intellect. How can that be? Because we already said it's better to operate early. So why would operating on them again later create some benefit? Next slide, please. So since that was the data we had, so let's try to figure out why. Next slide, please. It comes along with some groundbreaking work that was done by two researchers at Boston's Harvard at looking at critical time periods in initially newborn kittens. Basically what they did is they took a newborn kitten litter and took half of them and closed one eyelid with stitches and then let both groups go to about 6 months of age. Next slide, please. Actually, not quite that long, 3 months of age. But anyway, this is a very active time for the brain. There's all kinds of synapses being formed. We all know that for prenatal life. Next slide, please. But it also occurs in postnatal brain development as well, which I wasn't as aware of. Next slide, please. So the critical time periods actually turn out to be periods where you have to have connections of synapses at the right spot, at the right time, and the right number. Otherwise, your brain doesn't develop exactly the way it would if it had not had those problems. So that's kind of a real important thing to recognize. And it's kind of interesting that at 3 months of age, when they opened the eyelids of the kittens, kittens who had the eyelid closed for 3 months wound up being blind in that eye, but perfectly normal on the other side. And this is now interesting. In primates, it's 6 months, getting closer to what we actually use clinically. Next slide, please. So let's see, what should we do for effectiveness? I think I'll stop after I go through this because Andrew Timberlake took a great pains to show you some wonderful work he had done and group about the genetics. So I'll continue with this and to completion. Anyway, the idea is that we're trying to figure out the effectiveness of a procedure. And we want to know, again, the assessment tools. Next slide, please. The ERP, you also heard from Alex Jun, who's one of our fellows currently, basically saying that you can get a correlation coefficient between the assessments at less than 6 months of age, and it will be predictive in 0.81 correlation coefficient to kids who are over 6 years of age and actually up to 8 years of age in one study and much subsequently older. Next slide, please. The ERP we've shown before. Next slide, please. And we're now key. This is the critical thing is before anything has happened, before any surgery has happened, we can do in infants a test that has predictive capabilities for someone who's going to be working in school at 8 years of age. Next slide, please. And this is a quick review of a study we did on coronal sagittal metopic. The coronals, we didn't have enough numbers, so we just let them go. Next slide, please. Next slide, please. This is too much work for. This is a pre and post. Out of this is a kid who had, this is a group that had, the gray is the coronal, the control, whereas the orange is sagittal and blue is metopic. And the coronals will just leave out. And you can see postoperatively they get better, which is similar to what we just heard again from Alex Jung, that you have to operate on early and get it done correctly. to get the most improvement. Next slide, please. So which is more accurate, Bayley's or ERP? Next slide. Bayley's been used forever, and it's a very good test for assessments of kids, how they're doing very early on in life. The question is, was it predictive, much like the ERP is? And so we looked at neurocognitive testing after 6 years of age and found that there was, in fact, some differences. Next slide, please. We had them set up for all the usual propensity factors to make sure it's their same populations. Next slide, please. What we basically found is the Bayley's test did not correlate very well at all. This is the Bayley's 3 test, not the Bayley's 4, which has just been developed. But basically, it was less than 0.5 correlation coefficient, which is not highly significant. Next slide, please. And but then when you compare it with the ERP studies, we could get a 0.77 level of correlation, which does highly predict the future. We're still doing neurocognitive testings on these patients with the normal testing tools just to make sure, but the concept is that this ERP is reliable and very accurate, and certainly assuages any other test that we know about to date. Next slide, please. Next slide, please. So I'm not going to stop here because, again, this is where Andrew and others have spent a great deal of time, Alex John. We have all been impressed with the great opportunities this evaluation is now being afforded us. So again, you've already had some review of that earlier tonight, so I'm not going to repeat it and stop here in the time frame allowed for me for this discussion. I just want you to be aware this is a very active area, and I also want to thank my wonderful colleagues both at Yale and many other institutions in the country and abroad who are contributing to all this work. Thank you.
Thank you, John. I always love hearing about all this work that went into something that's really on the frontier of working with these kids. We're going to have a pretty good discussion when we're after Brian speaks, but our next speaker, or our next panelist is our co-moderator, or my co-moderator, Dr. Brian Andrews from the University of Kansas, who will be speaking on neonatal head-shaped deformities, aesthetic or functional problem.
Thanks, Justine, and thanks to the Plastic Surgery Research Council for letting me talk tonight. So the question is are these head-shaped deformities, are they just aesthetic, or are they both aesthetic and functional problems? I have no disclosures for this talk. However, I do have kind of a secondary thing to add, is that I do have a lab in which I study head and cranial defects and how they affect brain function and outcomes. In particular, I look at syndrome of the Trephian in trauma patients, and I have several fundings and awards as described below to look at those patients and how the skull, when it's present and not present, helps impact neurocognitive function. So my research is really kind of this thing about cranial neurophysiology, and how I explain it is that if you have an airplane engine and you take the cover off of it, as you see here, the plane will likely still fly, but it won't fly well. And that's the same with the brain, in that when the skull is misshaped or missing around the human brain, there's often neurocognitive and neurobehavioral dysfunction that occurs from it. And oftentimes that's very correctable by correcting the head shape. So in particular in this talk, we're going to talk about head shape anomalies in infants, and we'll look mostly at craniosynostosis and a tiny bit of deformational plagiacephaly. So in 2017, there was a great meeting in Hawaii where the American Society of Craniofacial Surgery and the American Society of Pediatric Neurosurgeons combined. And there was a question where they polled the audience at that time. And I know Dr. Lee and Dr. Persing were there. And the question was, is craniosynostosis an aesthetic operation or is it a functional operation? And the interesting thing is that the majority of the neurosurgeons that were polled said it was aesthetic, and the majority of the craniofacial surgeons in the audience who were polled said it was functional. And there's plenty of data out there, as Dr. Persing went over, that says that there are concerns for developmental delay in craniosynostosis. And this is just a few of those studies. At that same meeting, my group presented our first study on the topic. We looked at this rare case where we had 5 patients who presented to our clinics greater than 12 months of age. 2 of which had coronal synostosis. I think 2 had sagittal synostosis and 1 with metopic. And we were left with what to do with them as far as surgery and what were their behavioral outcomes. 4 of the 5 subjects were developmentally delayed, and we did repeated developmental testing on these children, and we found that within 12 months after surgery, they had significant increases in all aspects of their neurobehavioral development. And so we're quite excited about that. So going forward, we've continued to look at this in our group, and what's really come to light is metopic craniosynostosis. We know it's all increasing across the country. We know that there's a spectrum from mild, which probably doesn't need surgery, to severe, but there's this group in the middle that some of us struggle with, which ones are severe enough and which ones are mild enough that we operate or don't operate. And there's certainly groups, or certainly evidence from the Yale group that says that the severity of the deformity of the metopic craniosynostosis impacts neural dysfunction. And so we're certainly cognizant of that. But there's also controversies that there's other studies looking at metopic craniosynostosis with Dr. Cunningham and his group that shows that even severe craniosynostosis for the metopic suture does not necessarily correlate with cognitive development. And then we looked at our own group where we looked at severe, mild, and moderate deformational plagiocephaly, and we looked at whether or not that correlated with developmental concerns, and we found no correlation in that separate but similar head-shaped deformity group. So what we wanted to do going forward was decide whether neurobehavioral testing can be useful in surgical decision-making for infants with metopic craniosynostosis, especially for those infants that are kind of on the in the moderate spectrum. So we wanted to assess developmental outcomes, and we initially, for this study, we've looked at these late presenting because we live in a rural area, and for some reason or another, we seem to see more late presenting children than other areas, which we define as 12 months or later. And we decided whether or not cranial vault surgery had an impact on their neurocognitive development going forward. So we did a prospective non-randomized study over 4 years. We looked at late presenting, which was defined as 12 months of age, single suture metopic craniosynostosis that presented at the University of Kansas. And we excluded those who had previous diagnosis of developmental delays, those with hearing loss, and those who'd had previous intervention. We classified the metopic severity based upon Dr. Persing and his group's bifrontal endocranial angle measurement. It's a good, reliable measurement. There are certainly different ways to measure severity, but this is a very reproducible way that I like to use. We then met with parents afterwards, and we discussed whether or not they were willing to undergo surgical procedure. Some of these patients were pushing 2 years of age, and of the 10 patients we studied for, the parents wanted to elect observation. And then we used the Bailey scale, as Dr. Persing mentioned, for our study purposes because of its readily accessible use in our institution, but it certainly has its limitations. So we had 6 patients who underwent surgery, 4 parents and children who elected for observation. And what we found is that in the observation group, we really had minimal to no cognitive, language, or motor changes when we did serial Bailey's assessments. When we looked at our surgical group, we noticed quite significant, or actually not significant because of the N, but we noticed surprisingly positive results in their function where the motor function was statistically significant and others were likely going to be with further results. So here again, we see in our surgical group better changes in cognitive, language, and motor function in the surgical group and minimal changes in the non-surgical group. And there's certainly many limitations of the study, and certainly its small size is a problem. The study's age of these patients presenting late, which can be a confounder, as many of these patients may have had socioeconomic, access to care, neglect as the reasons why they presented late and why they were delayed. We certainly could use other methodologies for determining severity of metopic synostosis, but we do like the bifrontal endocranial measurement. And as Dr. Persing mentioned, Bailey's 3 is, and now which will become Bailey's 4 going forward, certainly has its limitations, but the beauty of it is it's easily accessible at most institutions, and we have multiple pathways in our institution for getting kids tested, both pre and post-operatively for that. And certainly our follow-up period needs to be examined going forward, and whether these changes were just simply transient in the first 12 months of surgery or whether they are long-term is to be determined. So in conclusion, I do think that standardized testing is a useful tool in the assessment of metopic craniosynostosis, and it might be helpful in some of these patients who are on the fence of whether or not a surgical intervention is warranted, especially in the late presenting children with metopic craniosynostosis. Thank you.
Thank you so much, Brian, Dr. Andrews. We will now open this up for discussion. So a couple ways, we're quite a bit ahead of schedule. And so if anyone wants to use a chat function, feel free to do that, or we can just kind of turn on and start talking. Anyone have any questions for Dr. Persing or Dr. Andrews, or some discussion points?
Hi, hey, Justine, this is Gary Rogers.
Hi, Gary.
Hi, John. Again, we go back to your data. I think the audience should understand that every single study you quoted on when you're comparing groups, the Springs, the endoscopic, the group you did with Boston, which you didn't publish because there was dispute about the data, was all of those use the same cohort of patients that all have a Wexler IQ score of 115, which is actually one standard deviation above normal. You've never retested. You've done hundreds of patients at your institution over the last 30 years, and yet you've never sought another group of patients. So the last study with Lisa David, 75% of the patients were the same patients you used back in the 2014 study that myself and other people, including Michael Speltz and others, chastised about the abnormal high IQ. And so I think, again, as I quoted, I put in a discussion last month, it's hard to understand how doing a large, it's one thing to talk about deterioration. It's another thing to say that you operate on these kids at a very young age and you bump their IQ score up a standard deviation. That's what you're basically saying here. Can you, I don't know why we keep talking about this, but it keeps coming up at every meeting that we discuss. And my understanding with Mark Proctor and the Boston group was they brought an independent examiner from Ohio who said that there was no difference when you normalize, and the study never got published because they would not, nobody would agree on pushing this forward and saying there was a difference. Independent study, Dave Zurkowski, who's a Harvard 100,000 publications, one of probably the most preeminent biostatisticians in the world, reviewed the data, agreed with the Yale statistician, agreed with that. And that study never got put in print because it was actually squashed by the group in Ohio who came in. Do you disagree with that? John?
Yes, Gary, I do. But thank you for your comments. I think the discussion concept is a very good idea because I think it is important to get the right answer. What I'm getting out of that, and I certainly, we jointly decided, Mark Proctor and I jointly decided to go ahead and have independent people going through. And there are a lot of factors. It wasn't just one element that ultimately led to just continued disagreement. And it hadn't to do just because the IQs were different. It was just, there's the whole things about the setup of the design of the studies and things like that. There's much more to it than that. And I actually talked to Mark and I said, Mark, particularly you, Gary, had been indicating that we were trying to hide data or something like that. That was not the case. And I said, I understand there are some notes going around describing that this is just something that, how do I put it, is just being misinterpreted and was not something that should be in the open channels for discussion by people. In other words, you put data out there and let people try to analyze it from multiple different points. And these are not just minor people who are looking at it from either side. These are people who are thoughtful and try to figure out ways in which maybe the data would be more understandable to everybody. We took out the top people who had IQs of a certain thing, and actually that was not received well, despite the fact we took out what we thought was very appropriate thing to do, not knowing what the answers would be. But why don't we just take out the people who had high IQs?
I know, Joe.
And then, hold on, let me just finish, Gary. And then when those things were done, the achievement tests and the learning disability pattern was very much the same. So again, Mark is the one who said, go ahead and you can go ahead and present it as you wish to. He was the one who came to the conclusion that, well, we're not going to wind up agreeing to agree. And then since it was already being said by you and others, that it was that we were trying to hide the data, that it would be inappropriate to do that.
John,
so
nobody
that's
says
why
you're
I'm
hiding
out here
data.
today.
John, let me interrupt you for a sec. No one says you're hiding data. The problem is you've used the same
Yeah,
cohort of
that's
patients
true. We have
every
some,
single
and every
study.
time we have another patient, we just put them in there. It's
But you haven't. But you haven't.
They
You
are
haven't put-
still from both Virginia and from Yale and
John.
from any place that wanted to be involved. We have some options
cohort
at
you
other
use-
places, and that
Stop for a
would
second.
be something that we could put in there.
Let me interrupt you for 1 second. Every study you've done, the revision study you just showed, the study that was done with Lisa David, the study that was done with Mark Proctor, and the study that was done in 2014, all of those use the same 75 to 100% of the patients in your cohort with the same group of people, these same 45 kids that have an IQ that is to a standard deviation above normal. You, instead of going back and retesting a new group of kids and getting rid of that information, you chose to continue forward using a group that is heavily skewed. No one would argue represents a normal standard. There's absolutely zero reason to believe that doing an operation on a kid at 3 months and putting him through this kind of surgery makes him a standard deviation above normal IQ. You keep spinning this stuff. It's just crazy. I don't understand. I really don't get
Gary,
it.
let me just go back to it again. There are a couple of things that are still not correct here. One, we're not hiding anything. We're not just limiting it to the patients that we've already seen. Hold on, Gary. The thing is that all I'm saying is that every time we have another patient that comes in, we put them in the study. And it is a slower accrual because we don't get 100 cases a year. We get a smaller number, and as a result, we just take what comes in. And that's why I think there was 25 or some percent that was done between the time that we did our study and the study that was done by Lisa and Mike Alperovich.
So between
and there is no, and this is also from the University
of Virginia. Wait a second, let me go back to your point, John.
And we also, remember, stop for a second, when we also took out all the patients that were above 120, that was an agreed upon thing. Okay, we'll go ahead and do that. And then when we got the results back, all of a sudden it wasn't a good thing to do. So there's a changing pattern going on. I agree, first of all, Gary, I like the fact that you are scrutinizing, that's fine. What I think we ought to do, in fact, is that what I have asked others to do, and I was, unfortunately, until COVID came along, and also with Dominique, not Dominique, but the Paris group, we were going to do a study, having them look at specifically what you were saying. Let's go to a different spot, look at both the strip craniectomy group and the whole vault, because on Famolad, they do the two different types regularly, and would have good numbers. And the plan between Eric Arnaud and me was that we were just, whatever comes out of the data, we're happy to look at, we're happy to promulgate around the world, and hopefully it'll be helpful to people in making decisions. We realize this is a difficult problem. We realize you're trying to come up with the best thing. You're not trying to do anything negative. But what we're trying to say is we want to have other studies out there who can, there can be other studies out there that may be able to address this.
John, can I just point one thing out? Between 2000, Yale is a high volume craniosynostosis center. I know what you guys do for volume. We're part of the consortium for anesthesia. You telling me between 2013, when your data collection stopped, and 2019, when your data collection stopped with Dr. David, you guys had to rely on, you have 75% of the patients in the study with Dr. David from Wake are the same kids in the 2014 study. You telling me you only added 20 new patients to the study? I mean, it's unbelievable.
I can tell you that everybody who gets operated on gets asked to participate in the study. There's no holding back on anybody. And those who participate are the ones you see in these studies.
May I ask a question? I think this is this discussion is a good discussion. Obviously, it's a emerging field and emerging portion of our practice, and really the data, even though it's been there for a minute, it's still, in the grand scheme of things, very new. I guess my question is to all our craniofacial surgeons in the audience, including Brian and everyone, like what's a general feeling in terms of how are people counseling parents? Are we talking about this data at all? Are we offering endoscopic or not offering endoscopic? And I was wondering if people in the audience could maybe comment on this. We'll start with maybe Brian.
Yeah, so I mean, it's certainly a difficult topic in that there's many confounders to get a straight answer on it. And certainly, I think from my perspective, seeing lots of late craniosynostosis due to geographically being in a large rural area, I think there's certainly some parenting that comes into play, as well as the access to care that patients are getting, which impacts child development. And I think that parents who show up at 3 months of age or 4 months in our ideal endoscopic patients certainly are going to spend more time and interact with their children more than the ones that I'm seeing that show up at 18 months of age and have their first physician evaluation at that point. But I do think that it needs to be discussed, but I don't think we have any answers to give patients yet on whether or not there are long-term sequelae with early or mid or late interventions for craniosynostosis, or observation for that matter. And certainly looking at that earlier study on the normal cephalic sagittal, there's concerns on that that are yet to be determined.
Mm-hmm. Anyone else have any comments in terms of how they normally counsel in the audience? Maybe Chris, you want to talk?
Yeah, sure. Apologies for my casual demeanor. I think this is probably the first research council meeting I've been a part of, and I've not worn a tie. This is a really complicated subject, and it was interesting to hear Brian's summary of the neurosurgical meeting, because the patients will go to the 6th floor clinic and the neurosurgeons will tell them, this is just a cosmetic operation. Go downstairs and see the craniofacial team, and they'll come and see me and John and Joanna, and we will say, well, there are some other issues that we need to pay attention to. And, in the last 4 years, we've moved into endo strips, mainly because of, I guess, pressure from families, because they realize what's going on out there. So we're offering it to them. But I don't think I actually get into this whole sort of neuropsychology, neurodevelopmental issue, mainly because I'm still unsure. And I'm listening to all of the data. The papers by Andrew earlier about genetics, to me, were eye-opening, and we're learning more and more about genetics. And I don't think we have the answers yet. So I counsel families and say, this is something that we need to keep an eye on. We continue to follow them carefully. And we tell them that, the incidence is small, but that it's real. And the issue of surgery and the influence of surgery is something that I still don't have a proper answer for. So, what do you say, Justine?
I actually talk about John's data.
Mm-hmm.
I talk about it a lot, and then we talk about the as Gary had mentioned, criticisms and stuff, in detail, and parents decide how they want to go. I personally don't do endoscopic, so if they do endoscopic, I'll refer to somebody else, or if that's what they want, I'll refer to somebody else.
Hey, Justine and Chris, I think one thing you have to remember is, if you go back and look, there's been many neurocognitive studies done on open vault surgery for sagittal, including Washington has a huge cohort. They've had there's never been a study ever, besides John Persing, that's shown that their IQs are higher than normal having an open vault surgery. So this is a unique data set that has been unduplicated, unsubstantiated by any other researcher in the field ever. And that's the problem, is that this data set that keeps getting spun is a cohort of about 40 kids that have an unusually high IQ for whatever reason, whether it's just fortuity or whether it's the way it was done, the testing that was done, I have no idea. But if you take that and contrast that with all of the other papers that have ever been written. Go back and look at Cap Simon's data. Go back and look at the big cohorts of patients with hundreds of patients. No one's ever shown that these kids get smarter because you take their cranium apart and subject them to a big open operation at 4 months, 5 months of age, except for Dr. Persing. That's the problem, is this data set. You should never reuse this data set again, John. You should never reuse this data set. You need to do new patients. You guys have enough patients at Yale. You can do a new cohort of patients, have an independent person review the neurocognitive stuff instead of your own people. And then, I'll buy into it. But I have a hard time buying the fact that this
let me just give you a little bit. That's our philosophy to begin with. I don't think we're really that far afield when it comes to going ahead and trying to figure out the answers. What I do think is kind of interesting is there's a lot of poor analysis of data. For instance, you mentioned Cap Simon. The Simon paper that, let's say, it was, I think it was Jeff Marsh who had some sagittal synostosis patients. And they did the Bailey's 3 test on them preoperatively and then 1 year postoperatively, which is a very poor design to begin with, to be honest with you, in the sense that they were trying to predict whether the surgery done by Jeff Marsh, whole vault or whatever, was in any way beneficial to the patient. What they found was that there's no difference. Interesting, but the issue is that Bailey's then has been criticized, the Bailey's 3, which is which has been criticized roundly by even the people who developed the Bailey's test as being non-predictive. If you can get people who are doing the same sort of testing we're doing, that is the ERP stuff, or we're doing a lot of functional MR stuff, we're doing a lot of very intense analysis to make sure we're right, because we recognize this is not going to sit home with everybody. The idea is we're trying to see it from multiple different pathways, which are all pretty sophisticated. Some of them have very strong records. ERP should be done by everybody who's going to make this discussion. If you're going to do preoperatively what's going on, you don't want to do a Bailey's 3, and maybe the Bailey's 4, we'll see. I mean, it's just been out for a year or two, and they're now trying to figure out whether it's going to have predictive value in it. That would make sense. I'm happy to have this go to any form of scrutiny that there can be, but you have to have reliable, accurate testing before you can start to make conclusions, which I don't think any of the things that you've mentioned have been actually done. Now, I have great respect for also the Washington group. They're very bright people, and they're doing a lot of very good analyses. So I'm not saying that it can't be done, and I would more than welcome a collaborative evaluation of multiple institutions that have different viewpoints. This is not a problem.
It is a problem because if you can guarantee me that I'll never see that data set again, I will never. Listen. I celebrate a lot of the things you've done. Don't get me wrong. My commentary here has nothing to do at the age of timing of surgery. I think you've done well with all that stuff. The issue is this single cohort of patients and the idea that somehow this open vault surgery is better than the other options that are out there that actually, by the way, produce normal IQs, which is what we'd expect. We wouldn't expect kids to be super normal from having the surgery. So unless you think this somehow is making kids brighter, like I told you, and we were out in Paris, you can make the kids standard deviation. I'll bring my own kids out there to Yale and have you operate on them right now. If you can make them.
I'll be happy to do that for you, Gary. Let me just mention one quick thing, though. Let me just say that this is not going to be black or white, meaning that Andrew did some absolutely outstanding work. But what is interesting in the study we haven't that hasn't been published yet, but basically the story was he did genetic testing, and genetic testing is a heck of a lot stronger influencing factor than what any of the surgical procedures are. In other words, whether it's whole vault or a strep craniectomy, there's probably a reasonable, at least in my thinking, it seems to be that there's a difference. On the other hand, if you have a concomitant significant loss of function type of anomaly, you're going to have dramatic changes. And I think it's not just a all or none. I think there are variations in the theme, and there'll probably be factors that are partially expressed, incompletely expressed, fully expressed, And all those things may be playing more of a role than what type of surgery we do or when we do it. I think it probably is that way. But at this time, the thing that was just, again, Alex, John, and Andrew Timberlake wound up doing a very cool study where they looked at people who had their exome genome looked at and showed that there were very significant factors. And guess what? Some of them who had that irregularity had tremendous neurological deficits. Another group of them with that same irregularity had nothing. No irregularities in terms of function. So it's a much more complex thing, and I think it is being worked out. But I just want you to know that it's not going to be, you're just going to do one little test and it's going to be there. It's going to be a compendium of tests and information, including functional MR, including ERP, whatever else you want to put in there to come to our conclusions. But I don't mind that there's still some debate, but also I also think it's perhaps a little too premature to say just because a Bailey's test is abnormal that it is something predictive of the future.
So maybe John and Gary, I can ask you, what's your messaging to the parents? This is what I asked Andrew earlier, because, you know, parents come well informed, but at the same time, it's a complicated subject that I'm having a hard time wrapping my own mind around. So what do you actually tell the parents when you see a child who's 2 months of age with sagittal or metopic synostosis?
Yeah, do you want to ask me or you want to ask
Yeah,
Gary?
John, yeah, you can start. Yeah, I'm interested.
Okay. What I say is that there are two different forms of surgical approach. I always tell them there are two different options. And obviously, since I have a bias in mind, I would assume that I'm probably presenting them differently to people than perhaps Gary would. But the way I do it is I say that there are some distinct advantages to a strip craniectomy. It's shorter operating time, so the slower risk, shorter hospital time, et cetera, and that's very appealing. And I can understand if you wish to go that route, and we'd be happy to help you with that. Then the second part of it is I'll say that we've done some studies that indicate that may not be as effective, but it's in a range where both people have IQs that are above 100 by and large, and they do reasonably well. But then I keep coming back to, wait a second, remember when I got here in 1992, these people were quite a bit different than what I understood at other institutions that I worked in before. And as a result, in the back of my mind, I'm trying to figure out whether I am overselling the strip craniectomy. I could be wrong, and I know there are many people around the country who would clearly do it differently than I do, but I do make a big point of the fact that you have options.
Mm-hmm. Gary, what do you say?
Well, I think the benefit, John, you're a big, I do agree with your data on early intervention, because there's actually another group subsequent to your study that did the same thing and came up with the same findings. So you have validation that perhaps, and this goes back to Renier's study 35, 40 years ago, that showed that kids who were operated on early, I think they did that study where they had two different cohorts, early operated, late operated, the late operated do worse. So I think there is some legitimate reasons to think about operating early. I think the value of endoscopic actually is that you do it before 3 months of age. It is the earliest intervention that I can see doing at that age. I don't feel very comfortable doing a 3-month-old vault, regardless of recurrence or not, just because of the size of the patient and the morbidity of the operation. And so I think it gives them an early release. And I'm not arguing that's the only, I mean, there are certainly failures to that operation, just like there are with open vault. But in my mind, that's an early opportunity release. I do think, getting down to what we talk to patients about pressure, if you look at Steve Wall's studies where he did interventional monitoring, he found that late operated sagittals, the pressure incidence is up to 44%. I think there is reason to tell parents this is not a cosmetic operation. This is, listen, I heard that same baloney and I still hear it from neurosurgeons. I disagree. The data would suggest, I think your data on age of operation and the subsequent study on that, going back to Renier way back when, the same data, and the pressure incidence that Wall, there's also a group out of Japan that shows the minimal phenotype sagittals operate on late up to 60%. have elevated intracranial pressure. We could debate about what that is, whether it's 10 or 15 millimeters of mercury, but it's enough for me to think this is not something I think you just want to dismiss and let a parent go. But I think in terms of the operation, I like endoscopic only because, and listen, I have no stake in this. I don't get paid to do endoscopic surgery. I don't even go in the operating room. I lose half my volume. I do this because I think it creates I think there's enough studies out there. The phenotypic correction is very, very comparable, if not better in some instances than an open vault. You don't have the coronal incision and you can release them early. So if I can do something in 30 minutes where I get this, I would say the group for Oxford, the group that in the UK groups are starting to move toward that. I mean, they're very, very objective, just like you guys up in Canada. I think at the National Health Insurance, they don't have the monetary drive to do bigger surgeries and more invasive stuff. And I think they look at it and say, why are we doing this? And I think we will see data coming out of the UK that's probably going to be very refined and very thoughtful about this operation. We'll find out. I think it's out there. But my issue with the data that John has spun over the years, and I'm not giving you a hard time with the data, John, but it's a same, you need to redo that. You need to redo another cohort. Quit using the same kids. If you do that, you'll never hear another word out of my mouth. I promise you.
Gary, I think the point has been made.
Good. I want to make it very clearly. Thank you. I just want to make sure.
Can I just mention one quick thing, though? Critical time periods, and this is kind of an interesting feature. That is, it's not just a matter of operating early. It's doing an adequate operation early. And that's what I'm concerned about. And again, it might be just, the way I think at nighttime. I think the point here is that there are critical time periods for neurocircuitry to be in the right spot, the right amount, and the right time. And if it doesn't occur, you get disability, or you get some irregularities in the way the brain, at least on functional MR, you get a different pattern than if you had a normal pattern of brain development. So there is something else that happens, even with surgeries in the best of hands and the best of times. But there are critical time periods. And I think that's what I'm concerned about is, yes, you can go earlier, but if you don't release it completely earlier, then I'm not so sure you've done the right job.
But John, let me go back. There's two things.
Let me just finish the statement. So the thing is that if it's open wide, and you can, and particularly if you take a look at some of the studies that Mark, what's his name, did at Pitt in animals with a rabbit.
Mooney.
Mark Mooney, thank you. And he basically showed that in the areas where there was compression, that the vasculature was different. And also we've now seen that neurocircuitry is also different. There is something there about doing it adequately. And the strip craniectomy isn't quite as good in terms of expanding that vault space for the brain to grow. And I think that's kind of important, at least in my thinking.
So let me just go back. If you look at some of the 3D studies, Cam Patel, who's one of my former fellows, let me go through this. There's a lot of studies on, there's two things we can alter as surgeons. We can alter the shape and we can alter the volume. You agree? And those two things, if you look at all of the studies that have been done on this, first of all, we'd agree that the sagittal kids generally have a normal volume to start with anyway. You did that work, my friend. That was your data. And so I would argue that there's not so much a volume issue as a shape issue. If you look at all the studies that have been done on morphometrics with endoscopic release, and these are done, again, you're doing this at 2 months of age, 6, 7, 8 months of age, their cephalic index, their shape based on 3D imaging is very comparable to what you'd get with a very good open vault. Not everybody does an open vault well. I've seen lots of lousy sagittals, we talk about it like it's one operation. You do it different than I do it different than someone else does it. Endoscopic surgery, the one thing you say about that is, generally speaking, it's a fairly uniform operation. There's very little you take out a piece of suture and you call it a day. You put a helmet on their head. Open vault surgery, frontal lobe advancement, all the things we do, there are infinite variations of how they stabilize it, how we move it, how far we move it, how we release the base, like in sagittal, whether release the base or don't release the base. I've seen surgeons do it every which way but loose. So I think we can't talk about it as one one standard operation. I don't know. I have a hard time believing if the shape is normal and the volume is normal at 6 months to 8 months after an endoscopic release, it's not giving you the same changes that you would get doing an open vault, minus the big incision, minus the blood loss, minus the anesthesia, minus the morbidity. And minus the plates and all the things you got to use to stabilize it.
I know I've extended this well beyond which is appropriate. Justine, if you want me to shut up, I'll do right now. But if there's one other thing that I just think you ought to put into your line of thinking too, and particularly those who are interested in strip craniectomies, is that we did a study. I don't know which one you're referring to, but the one we looked at was what is the brain at certain ages of development in people who had sagittal synostosis but did not have it repaired. Others was the natural history of people with sagittal synostosis. And basically what that showed is that as you have sagittal synostosis untreated for longer periods of time, your brain continues to grow and so does your head circumference. And in fact, it has to do with not hydrocephalus, it has to do with increasing brain parenchyma, whether it's gliosis or some other neural circuitry, we don't know. But the volume in sagittal synostosis, in untreated sagittal synostosis, doesn't go down with time. It goes up. And if you've got a rigid box that is trying to get a little bit more room for the brain to grow, it's going to be harder to do. So that was, I forgot, Sushan Lee is the guy who was the first author on that paper. It was about 10, 15 years ago. Anyway, I'll stop talking here. Go ahead.
Well, John, I think your discussion about age ties in really well with what Brian was talking about with the delayed presentation and then actually finding a difference despite the delay in presentation after treatment. I wonder, Brian, did you have any thoughts about that? Do you think they just started worse? Because I think their scores were a little bit lower, right?
Yeah, I would caution interpreting my data as the surgery itself fixed it. Mm-hmm. I think that it's biased and that these patients showed up late and that added a lot of confounders to it, and probably socioeconomically and parental attention that was applied to these children, and early interventions that were provided from outside the house that possibly the kids could have benefited from. And I do think that once we operated on these children, this small group of 6 that had surgery probably had increased parental stimulation and involvement, as well as we were able to then enroll them in outside therapies as well. We did also enroll the non-surgical group, but it's difficult to track how well the parents took advantage of the enrollments where I'm at. And so we can get state to come in and do developmental services for them, but we can't really track how many times they visit and how long those visits and how well they were perceived. So it's a difficult topic, and I don't want to make a conclusion that the surgery itself was the factor that it had equaled a better developmental outcome, but it did show it, which was nice and which was what we were hoping for, and that it was not just an aesthetic operation, especially when someone shows up at 26 months of age. It's difficult to do an aesthetic operation at that point in my head.
I think there was something else that we were talking about offline, but actually let me go to Mike real quick, Mike Olinko, because I saw he turned his camera on, seemed like he was trying to get a comment in.
Yeah, well, I really appreciate this panel. I think it's an ongoing discussion. Michael Lincoln from Vanderbilt, everybody. For those of you who I don't know, we'll get to know. But I think, one thing that I think we really need in this field with craniosynostosis is staging the patient, right? Just like you would stage a cancer, it's stage 1, 2, 3, 4. I think we can all agree there's different expressions of the disease process, whether you believe it's intrinsic or extrinsic. What's the state of the brain? What's the head shape? How do those two relate? And moreover, how does that relate to how the kid performs and how do they do on tests? Obviously, I think we can all agree when taking an IQ test, just like an SAT or ACT, it's hard to control for every single variable, although a lot of the studies that the person groups and others have done have tried to control for everything, maternal IQ, interventions like Brian was saying. It's very difficult. And I think, I was talking to Jesse Goldstein and his group, what they're doing with cranial rate. I recommend you guys look at kind of that head shape kind of analysis thing he's doing for metopics. But I think our field could really do with some staging these kids. What's the state of the brain even before we do surgery? That are there kids that already have white matter tract changes that you could pick up with DTI? or functional MRI deficits that you can detect. But right now we're just looking at a CAT scan. We're kind of flying in the dark and just offering surgery to everybody, because we know that it's for sure a head shep operation. We can surely, everybody can agree on that. But which kids is it a brain operation that this kid will be better off from a cognitive standpoint by doing something? That, I think, is really the unknown and kind of the holy grail in the field. And I'm happy to say we have John Persing and Mike Alperovich, his junior partner, as kind of visiting professors, and I'm working with Mike very closely on a project to kind of look at some advanced neuroimaging to kind of look at this before we can even answer the question of is endoscopic better for the brain than craniosynostosis. I think we need better tools, better stage these patients. Thanks for the floor. Just, thanks, fascinating discussion.
Thanks so much, Mike. I think your comment is just exactly how all of us are feeling, and just another plug for Andrew Timberlake's work. I think that is probably something that would really help us in terms of trying to stage something that we're no longer dependent on sort of micro or macro or even radiologic kind of findings, but actually looking straight to like what are the genetic issues and how do we stratify based on genetics. So one other thing, I guess, before I went to Mike was Brian and I had been having this discussion like offline about, maybe I'll let Brian take it, but, this discussion about the metopics and also like, what are we doing with the moderate metopics?
Yeah, I guess I'd open that up to the audience. Maybe does anyone else have a algorithm or set way to deal with the group that kind of fits into non-severe, non-mild, and which ones get surgery, which ones don't when you're in this middle group? I mentioned John's endocranial bifrontal angle. I like that, but I certainly have plenty of those who I can find that measurement as being severe, but the rest of their forehead maybe is not as severe as that measurement is. But it is nice when I do research to have a objective number that I can measure out and equally or easily reproduce. So is there other ways that people use to deal with the moderate group?
Chris, I feel like you have a lot of like things that you guys have developed when it comes to measurements. Do you have a cutoff or anything like that?
So I mean, I hate to admit this, but it's very much a parental decision unless there's a functional concern going on. And our screening tools for ICP basically focus on the ophthalmologists that we work with. On occasion, we'll do an intracranial pressure assessment. And I think we present the information. The one thing that I think really helps is linking families with other families that have gone through surgery. There are significant Facebook groups that are out there, and often they'll come in and they're already connected. And I think that's what drives the decisions. The challenges that I see are those very mild metopic ridges. And I never know whether they're true metopic ridges or extremely mild forms of true metopic synostosis and what to do with those. And we do have some families that say, no, we're not interested in surgery, even though as a surgeon, I might look at it and go, I think this is something that I would operate on if this was my own child. So we don't necessarily advocate for those parameters for cutoff. And, parents often say, well, what do you think? Do you think this is mild, moderate, or severe? And it's a difficult thing. The flip side of the equation is that I mentioned earlier, we're doing endo strips, and my messaging to families is that the predictability of outcome isn't quite so good as doing a whole vault or anterior vault reshaping. And very often, what the parents think in terms of outcome is not coordinate, doesn't coincide with necessarily what I think as a surgeon, because I'll look at the results and I think, well, we should do better, or we maybe talk about doing something else. And the parents are saying, no, it's fine. Looks great. Looks fantastic. So I think we need to be cognizant of not patient reported, but parent reported outcome measures when it comes to outcomes and looking at these. And I have to say, Michael, I think your idea of staging is really, really valid. And it's almost like you're creating a passport with the different arenas of genetics and morphometrics and developmental outcomes that will drive maybe opportunities for treatment intervention. So it's a great idea.
Could I just applaud that statement and also add that I think we're not investing as a group into better assessment tools before surgery. In other words, the only real test at this point is not any of these neurocognitive tests you can get, like a developmental quotient or even the Baileys. We need to have something that is objective, that is proven, and the ERP is the only thing that I know of that you can take preoperatively and then measure with great correlation when the kids become school age, when you can do real testing. That's the only thing you can do preoperatively. A corollary of that is the functional MR. All of us are at big institutions. We need to have functional MR on every kid. You can't do them with sedation and expect them to be valid. So you basically have to do them. In other words, they have to be sleeping without any barbiturates or anything to keep them quiet, because the noise with the functional MR is like having a jackhammer on top of your head while you're trying to sleep. So the idea is that if we can get those things pre and post, in addition to what Mike was saying, I agree with the idea of assessment, do that, get a real assessment, not these other things, and you'll get objective data, because that's the only objective data that's at least available that I know of.
Yeah, couldn't agree with you more, but you know, that's definitely, we're doing these things saying that it'll help a kid functionally, but we never actually, in terms of, you know, our standard of care, we're not measuring. We never really been measuring. We just kind of feel the head is, and if it's big, round, and, you know, looking normal.
Mm-hmm.
All right. Any other comments out there? Because I think we're about to wrap up our discussion a couple of minutes early. Well, I'd like to thank everyone for a wonderful panel discussion. I can always count on our own field for having a lively discussion, but it's a lively discussion about some a very important topic. And so I'd really like to thank Dr. Persing and Dr. Andrews for sharing their work, and of course, everyone, including Dr. Forrest, for contributing to this discussion. So, and thanks for making our third night of the pentathlon a success. Hopefully, I'll be seeing everyone in person for next year's PSRC. To add an extra element to the pentathlon program this week, the tech committee, the PSRC tech committee, is hosting a Instagram live event. We call it the closers. So the closers are basically a couple of our medical students and residents. It's a little bit tough to speak up during our own discussions on Zoom, but they're going to have a whole discussion recapping the night. And special guest tonight is Dr. Greg Borchell, who will be maybe talking about craniofacial, maybe talking about some nerve stuff, and it'll be pretty much a play-by-play. So anyone with Instagram, go ahead and support them on Instagram Live. So this Instagram Live session will take place immediately following this, and the closers may comment on the live panel or recap highlights. Closers tonight are Michelle Oberoi, Vivian Hu, and Nirbe Jain. Thanks, everyone. Good night.
Good night.
Thanks, everyone.
Thank you.